Hello and welcome. Do you want to successfully complete the D446 OA exam? Then you are in the right place. Our website has free questions and answers for the D446 OA exam. We know OA exams are tough, so our guides and practice questions are all free. With over 100 plus success stories, we have proven our videos will help you pass your exam on the first attempt. In this video, we will cover questions from respiratory disorders, cardiovascular health, neurological conditions, endocrine dysfunction, renal management. So, let's get started.
1. A nurse is caring for a client newly diagnosed with chronic obstructive pulmonary disease. Which underlying pathophysiological process best explains why this client develops persistent airflow limitation and progressive shortness of breath that worsens over time, despite treatment? A. Sudden bronchial muscle spasms only. B. Temporary allergic response to pollen. C. Chronic inflammation causing airflow limitation. D. Viral damage to alveolar membranes. Can you guess the answer? Correct answer. C. Chronic inflammation causing airflow limitation. Explanation. Option C is correct because chronic obstructive pulmonary disease involves long-term airway inflammation that leads to permanent narrowing, excess mucus production, and reduced airflow. This ongoing process fully explains the progressive nature of the disease. Option A is incorrect because sudden muscle spasms describe asthma attacks, not COPD. While bronchospasm can happen in COPD flare-ups, the main disease process comes from permanent tissue damage and chronic inflammation. Option B is incorrect because a temporary allergic response describes seasonal reactions or mild asthma. This condition does not resolve between episodes and stems from sustained damage, typically from smoking, not short-term immune triggers. Option D is incorrect because viral damage to alveoli fits better with acute pneumonia or post-infection complications. COPD develops mainly from long-term exposure to smoke or pollutants, not a single viral event. Alright, let's break down what's actually happening inside the lungs of someone with COPD. This question tests whether you know the difference between a sudden reaction and a long-term disease process. Chronic obstructive pulmonary disease is exactly what the name suggests. Chronic, meaning ongoing and permanent. The airways stay inflamed over years, usually from smoking or breathing in pollutants. That steady inflammation thickens the airway walls, pushes up mucus production, and destroys the delicate air sacs called alveoli. Once that damage sets in, the airways narrow and never fully open again, which is why breathing keeps getting worse even with medication. Option A describes asthma, where muscles clamp down suddenly and relax. Option B fits seasonal allergies, not a permanent disease. Option D matches viral pneumonia, which is short-term, not chronic. Here's a WGU D446 OA exam tip for you. When you see the word chronic paired with airflow limitation, the answer almost always points to long-term inflammation and tissue damage. Remember this pairing, chronic equals permanent change, and you'll lock down these COPD questions fast. 2. A client with advanced COPD is admitted to the medical floor with worsening shortness of breath and fatigue. The pulse oximeter reads 85% on room air. The nurse begins oxygen therapy. What target oxygen saturation range should the nurse maintain for this specific patient? A. Between 88 and 92%. B. Between 95 and 100%. C. Between 70 and 80%. D. Between 99 and 100%. What do you think is the answer? Correct answer, A. Between 88 and 92%. Explanation. Option A is correct because COPD patients retain carbon dioxide and rely on low oxygen levels to drive breathing. Keeping saturation between 88 and 92% prevents suppression of their respiratory drive while still treating dangerous hypoxia. Option B is incorrect because aiming for 95 to 100% is the standard for most patients, but can be harmful in COPD. Higher saturation may suppress the respiratory drive and cause carbon dioxide to build up to toxic levels. Option C is incorrect because a range of 70 to 80% is dangerously low and would cause severe tissue hypoxia. This could trigger cardiac arrhythmias, organ damage, or death. Oxygen therapy must bring saturation well above this level. Option D is incorrect because pushing saturation to 99 or 100% in COPD patients risks knocking out the hypoxic drive that triggers their breathing. This can lead to respiratory depression and respiratory failure. To really understand this one, you need to think about how COPD patients breathe differently than healthy people. Most of us breathe because carbon dioxide builds up and signals the brain to take a breath. But in advanced COPD, carbon dioxide stays high for so long that the brain stops responding to it. Instead, the body switches to a backup signal called the hypoxic drive, meaning low oxygen is what triggers each breath. So if you flood this patient with oxygen and push their saturation up to 99 or 100%, you knock out the very signal that keeps them breathing. That's why the target sits between 88 and 92%. Low enough to keep the hypoxic drive working, but high enough to protect the organs from dangerous low oxygen. Option B is a healthy lung target and would suppress their breathing drive. Option C is dangerously low and risks cardiac arrhythmias. Option D pushes saturation too high for a COPD patient. Here's a WGU D446 OA exam tip for you. When a question mentions COPD and oxygen together, go straight to 88 to 92%. Recall hook. COPD sits in the 80s to low 90s, not the high 90s like everyone else. 3. A nurse is creating a discharge teaching plan for a client with COPD. The client asks about lifestyle changes that would most meaningfully slow disease progression and reduce future flare-ups. What is the most important teaching the nurse should emphasize? A. Sleep flat without any pillows. B. Drink caffeine to widen airways. C. Avoid all forms of physical activity. D. Stop smoking and avoid secondhand smoke. What do you think is the answer? Correct answer, D. Stop smoking and avoid secondhand smoke. Explanation. Option D is correct because smoking causes about 80% of COPD cases and continues to damage lungs even after diagnosis. Quitting remains the single most effective action a client can take to slow disease progression and reduce future flare-ups. Option A is incorrect because sleeping flat actually worsens breathing in COPD. It allows abdominal contents to push against the diaphragm. Most COPD patients sleep better propped up with pillows or in a reclining chair. Option B is incorrect because caffeine does not treat COPD in any clinical sense. While some compounds related to caffeine have mild bronchodilator effects, coffee or tea cannot replace prescribed inhalers or change disease progression meaningfully. Option C is incorrect because avoiding activity causes deconditioning and weakens respiratory muscles, making symptoms worse. Pulmonary rehabilitation and paced exercise actually improve endurance and quality of life in COPD patients long term. Let's look at what actually changes the course of COPD rather than just easing symptoms for a day. Smoking causes roughly 80% of COPD cases, and here is the hard truth. Every cigarette after diagnosis keeps damaging the lungs. Quitting does not reverse what is already gone, but it slows the slide and cuts the rate of future flare-ups more than any other single action. Medications help, inhalers help, but none of them matter nearly as much as pulling the fuel out of the fire. Secondhand smoke counts too, because the lungs do not care if the smoke comes from your own cigarette or someone else's. Option A tells the client to sleep flat, which actually makes breathing worse because the belly presses on the diaphragm. Option B leans on caffeine, which has no real role in COPD management. Option C bans all activity. but deconditioning speeds decline, not slows it. Here's a WGU D446 OA exam tip for you. On any chronic lung question, asking for the single most important teaching, pick smoking cessation first. Recall hook. Smoke in equals lung damage, smoke out equals slower decline. 4. A nurse is assessing a client in the emergency department having an acute asthma exacerbation with audible wheezing, shortness of breath during mild activity, and significantly increased mucus production. Which medication should the nurse expect to give first to quickly reverse the acute symptoms? A. Oral prednisone tablet. B. Inhaled albuterol rescue. C. Daily long-acting inhaler. D. Antibiotics given intravenously. What do you think is the answer? Correct answer. B. Inhaled albuterol rescue. Explanation. Option B is correct because albuterol is a short-acting beta agonist that relaxes airway muscles within minutes. During an acute exacerbation, it works as the first-line rescue treatment to open airways quickly and relieve life-threatening breathing distress. Option A is incorrect because oral prednisone treats inflammation over hours to days, not minutes. While often added during exacerbations to reduce swelling, it cannot open constricted airways fast enough to serve as the first emergency intervention. Option C is incorrect because daily long-acting inhalers prevent symptoms over many hours and work best when used steadily over time. They do not relieve a sudden attack, and you would never replace a rescue medication during acute breathing distress. Option D is incorrect because intravenous antibiotics treat bacterial infections, not asthma exacerbations. Asthma attacks come from inflammation and muscle spasm, not bacteria. Antibiotics would not address the airway narrowing, causing breathing trouble. Picture the patient in front of you, wheezing, struggling to pull in air, mucus everywhere. This is not the moment for a slow-acting drug or a prevention plan. This is the moment for a rescue medication that works in minutes. Albuterol is a short-acting beta agonist, and it binds to receptors in the smooth muscle wrapped around the airways, making that muscle relax within 3 to 5 minutes. The airways widen, air moves, the patient starts to catch their breath. Option A, oral prednisone, is a steroid that reduces inflammation over hours to days. Too slow for a crisis. Option C, long-acting inhalers, are preventers meant for daily use and do nothing for a sudden attack. Option D, IV antibiotics, treat infections, not the bronchospasm driving an asthma attack. Here's a WGU D446 OA exam tip for you. In any acute asthma scenario, the first medication is always a short-acting beta agonist like albuterol. Recall hook, acute attack equals albuterol, rescue in minutes. 5. A client hospitalized with a severe COPD exacerbation develops increased drowsiness, new confusion, and a dull headache within hours after the nurse starts oxygen therapy at 6 litres per minute by nasal cannula. What is the most likely cause of these new neurological findings? A. Worsening of underlying lung infection. B. Normal response to oxygen therapy. C. Carbon dioxide retention from oxygen. D. Caffeine withdrawal from hospitalization. Do you know the answer? Correct answer, C. Carbon dioxide retention from oxygen. Explanation. Option C is correct because high oxygen flow in COPD can suppress the hypoxic drive, causing carbon dioxide to build up in the blood. Rising carbon dioxide produces drowsiness, confusion, and headache, all classic signs of carbon dioxide narcosis. 2. Option A is incorrect because a worsening infection typically brings fever, rising white blood cell count, and purulent sputum, not headache and confusion alone. The timing links the symptoms directly to the new high-flow oxygen, not infection. Option B is incorrect because oxygen therapy should relieve hypoxia symptoms, not create new neurological problems. Drowsiness and confusion appearing after oxygen starts are never normal and always need prompt investigation to rule out complications. Option D is incorrect because caffeine withdrawal may cause mild headache, but not confusion or significant drowsiness in a hospitalized patient. The direct timing with oxygen initiation makes a respiratory or metabolic cause far more clinically likely. This scenario is a classic trap, and it catches students who forget that oxygen is a drug with real side effects. The patient came in breathing on their hypoxic drive. Remember, low oxygen is what signals their brain to breathe. Then the nurse puts on 6 litres per minute, a big dose of oxygen. The saturation climbs, the brain senses plenty of oxygen, and it slows breathing down. When breathing slows, carbon dioxide builds up in the blood. Rising carbon dioxide acts like a sedative on the brain, producing drowsiness, confusion, and that dull pressure headache. This is carbon dioxide narcosis, and it comes straight from too much oxygen, not from infection or caffeine withdrawal. Option A would bring fever and purulent sputum, not just neurological changes. Option B is wrong because oxygen should improve the patient, not create new problems. Option D is clinically trivial and does not match the timing. Here's a WGU D446 OA exam tip for you. If a COPD patient gets confused or sleepy soon after high-flow oxygen starts, think CO2 retention first. Recall hook. Too much O2 equals too much CO2 equals foggy brain. 6. A client arrives at the emergency department with crushing chest pain radiating to the left arm and jaw, along with diaphoresis and shortness of breath. Which finding would most clearly distinguish a myocardial infarction from stable angina in this patient? A. Pain persists despite rest and nitroglycerin. B. Pain occurs only during exercise. C. Pain resolves within 5 minutes. D. Pain has no associated symptoms. Do you know the answer? Correct answer. A. Pain persists despite rest and nitroglycerin. Explanation. Option A is correct because stable angina eases with rest and nitroglycerin, since the heart briefly gets more oxygen. But a heart attack reflects actual tissue death from blocked arteries, so pain continues despite these standard measures. Option B is incorrect because pain that occurs only during exercise describes stable angina, not myocardial infarction. Angina happens when the heart needs more oxygen than coronary arteries can deliver, and symptoms stop once activity ends. Option C is incorrect because pain that resolves within 5 minutes points to angina, not a heart attack. Myocardial infarction pain lasts much longer because the coronary artery stays blocked and heart muscle keeps dying without reperfusion. Option D is incorrect because isolated chest pain without any other symptoms is more typical of mild angina or non-cardiac causes. Heart attacks usually come with diaphoresis, nausea, shortness of breath, and a feeling of impending doom. Here's the cleanest way to tell a heart attack from stable angina at the bedside. Stable angina happens when the heart muscle briefly needs more oxygen than narrow arteries can deliver, usually during activity or stress. Rest or nitroglycerin widens those arteries. Oxygen supply matches demand again, and the pain fades within about 5 minutes. A myocardial infarction is different. A coronary artery is fully blocked by a clot, and the muscle downstream is actually dying. No amount of rest or nitroglycerin opens that clot, so the pain keeps going, often with diaphoresis, nausea, and a sense that something is very wrong. Option B describes classic exertional angina, not infarction. Option C, pain that resolves in 5 minutes, fits angina, not a heart attack. Option D is misleading because infarction pain almost always comes with sweating, shortness of breath, or a feeling of impending doom. Here's a WGU D446 OA exam tip for you. The single most useful distinguishing feature is pain that refuses to quit with rest and nitroglycerin. Recall hook. Nitro works equals angina, nitro fails equals infarction. 7. A nurse is caring for a client in the emergency department with a confirmed acute myocardial infarction. The nurse quickly recalls the MONA protocol used during the early management phase of care. What does the letter M in MONA represent for pain control? A. Magnesium given intravenously. B. Metoprolol given orally. C. Metformin for glucose control. D. Morphine for pain and anxiety. Do you know the answer? Correct answer, D. Morphine for pain and anxiety. Explanation. Option D is correct because morphine relieves chest pain, lowers anxiety, and reduces workload on the heart by causing mild vasodilation. This combination decreases oxygen demand during a heart attack and helps prevent further damage to heart muscle. Option A is incorrect because magnesium is sometimes used for specific arrhythmias, but is not the M in MONA. The MONA protocol targets pain, oxygen delivery, coronary blood flow, and platelet activity, none of which magnesium addresses here. Option B is incorrect because metoprolol, a beta blocker, is often given after initial stabilization to control heart rate and protect the heart. However, it is not part of the classic MONA and mnemonic used during the first minutes of care. Option C is incorrect because metformin treats type 2 diabetes and plays no direct role during an acute heart attack. It must often be held before procedures involving contrast dye, and it does not belong in the MONA protocol. MONA is one of those mnemonics you cannot skip, so let's lock it in. The letters stand for morphine, oxygen, nitroglycerin, and aspirin, the 4 early interventions for a suspected acute MI. The M at the front is morphine. It does 3 jobs at once during a heart attack. It kills chest pain. It cools down the anxiety that pushes up heart rate and oxygen demand. And it causes mild vasodilation, which takes workload off the damaged heart. All 3 of those effects help protect heart muscle, while the team prepares for definitive treatment, like cardiac catheterization. Option A, magnesium, is used for specific arrhythmias like torsades, not for pain. Option B, metoprolol, is a beta blocker added after initial stabilization, not part of MONA. Option C, metformin, is a diabetes medication and actually gets held before contrast procedures. Here's a WGU D446 OA exam tip for you. When you see MONA, translate it word by word. Morphine, oxygen, nitroglycerin, aspirin, and the M is always morphine for pain. Recall hook. M equals morphine, the heart's painkiller. 8. A nurse is assessing a client with heart failure who presents with jugular vein distension, pitting lower leg edema, ascites, and fatigue with activity. Which side of the heart is most likely failing based on these specific assessment findings alone? A. Left side only failing. B. Right side of heart. C. Both sides equally affected. D. Neither side, this is unrelated. Do you know the answer? Correct answer. B. Right side of heart. Explanation. Option B is correct because right-sided heart failure produces systemic backup of blood into veins. This causes jugular vein distension, swelling in the legs, and ascites in the abdomen. These peripheral signs point clearly to right-sided dysfunction. Option A is incorrect because left-sided failure causes pulmonary symptoms such as dyspnea, crackles, orthopnea, and frothy sputum. These findings show systemic venous congestion, not lung congestion, so the left side alone does not match. Option C is incorrect because biventricular failure is possible, but the assessment mentions no pulmonary signs like crackles or orthopnea. With only peripheral congestion findings present, the evidence points to isolated right-sided failure. Option D is incorrect because jugular distension, leg edema, and ascites are classic cardiac congestion signs and tie directly to heart failure. Calling these findings unrelated ignores the hallmark presentation of right-sided pump dysfunction. Let's walk through where the blood backs up, because that tells you which side of the heart is failing. Think of the heart as two pumps. The right side takes blood from the body through the veins and pushes it to the lungs. The left side takes oxygenated blood from the lungs and pushes it out to the body. When the right pump fails, blood backs up behind it, into the big veins and then into the body tissues. That is exactly what you see here: jugular vein, distension from neck veins that are too full, pitting leg edema from fluid pooling in the legs, and ascites from fluid building up in the abdomen. These are all systemic, body-side signs. Left-sided failure would back up into the lungs, giving crackles, pink frothy sputum, and breathlessness lying flat. None of those lung signs are mentioned here. Option A is wrong because left-sided failure shows pulmonary signs, not peripheral ones. Option C would need both sets of signs, and the question only lists peripheral findings. Option D ignores textbook cardiac congestion. Here's a WGU D446 OA exam tip. For you, peripheral swelling plus jugular distension equals right-sided failure. Lung crackles plus orthopnea equals left-sided failure. Recall hook: right side backs up to the body, left side backs up to the lungs. 9. A home health nurse is teaching a client newly diagnosed with chronic heart failure about daily self-monitoring. The client asks which specific action would catch worsening fluid overload earliest, before symptoms force a hospital visit. What should the nurse recommend? A. Checking blood pressure twice weekly. B. Counting urine output once monthly. C. Weighing self at same time daily. D. Measuring calf size each evening. Can you guess the answer? Correct answer: C. Weighing self at same time daily. Explanation. Option C is correct because daily weights taken at the same time reveal fluid shifts faster than any other self-check. A gain of 2 to 3 pounds overnight points to fluid retention before swelling, dyspnea, or other visible symptoms appear. Option A is incorrect because twice weekly blood pressure checks are useful, but miss rapid fluid changes between readings. Heart failure can worsen within hours, so a less frequent check cannot catch overload early enough to prevent decompensation. Option B is incorrect because monthly urine output tracking is far too infrequent for heart failure monitoring. By the time output drops noticeably, the client may already show major fluid overload signs and need emergency care. Option D is incorrect because measuring calf size each evening is impractical and unreliable. Swelling shifts with position, activity, and time of day. Simple daily weights give a clearer, more consistent picture of fluid status. Daily weights sound almost too simple to matter, but they are the single most reliable catch for early fluid overload. Here's why. Fluid has weight. 2 extra pounds of water retention on the scale today is the same 2 pounds that will show up as swollen ankles and shortness of breath 2 or 3 days from now. Catching it on the scale first gives the patient time to call the provider, take an extra diuretic, or adjust sodium intake before they end up back in the hospital. The rule is same scale, same time, same clothing. Every morning after the bathroom, a jump of 2 to 3 pounds in a day or 5 pounds in a week is the red flag. Option A, twice weekly blood pressure, misses fast changes between readings. Option B, monthly urine output, is far too infrequent to catch anything early. Option D, measuring calf size, varies too much with position and time of day to mean anything reliable. Here's a WGU D446 OA exam tip for you. For heart failure home monitoring, always pick daily weights at the same time, same scale. Recall hook: the scale catches fluid before the lungs do. 10. A client is taking both furosemide and spironolactone daily for congestive heart failure. The nurse carefully reviews the medication profile and considers how these two drugs affect potassium levels differently. Which statement correctly describes their combined effect on potassium balance? A. Spironolactone offsets furosemide potassium loss. B. Both drugs deplete potassium equally fast. C. Both drugs raise potassium levels dangerously. D. Neither drug affects potassium at all. Can you guess the answer? Correct answer. A. Spironolactone offsets furosemide potassium loss. Explanation. Option A is correct, because furosemide wastes potassium through urine output, while spironolactone spares potassium by blocking aldosterone. Combining them helps maintain balance, allowing diuresis without dropping potassium to dangerous levels that could cause cardiac arrhythmias. Option B is incorrect because furosemide depletes potassium, but spironolactone actively conserves it. Their effects on potassium move in opposite directions, not the same direction. This is precisely why clinicians often pair them in heart failure management. Option C is incorrect because furosemide lowers potassium rather than raising it. Only spironolactone can push potassium higher. Claiming both drugs cause hyperkalemia misreads furosemide, which is a potassium-wasting loop diuretic with opposite effects. Option D is incorrect because both medications have direct, well-documented effects on potassium handling in the kidneys. Saying neither drug influences potassium contradicts basic pharmacology and ignores why these medications often appear together. This question tests whether you know how two common diuretics balance each other out. Furosemide is a loop diuretic. It pulls fluid off fast, but it also drags potassium out with the urine. Too much furosemide alone, and you can drop potassium low enough to cause dangerous cardiac arrhythmias. Spironolactone is a potassium-sparing diuretic. It blocks aldosterone, the hormone that tells the kidneys to hold sodium and dump potassium. By blocking aldosterone, spironolactone keeps potassium in the body. When you pair the two, furosemide does the heavy lifting on fluid removal, and spironolactone protects potassium at the same time. That balance is exactly why clinicians prescribe them together in heart failure. Option B is wrong because these two drugs move potassium in opposite directions, not the same direction. Option C is wrong because furosemide lowers potassium, not raises it. Option D ignores well-known pharmacology. Here's a WGU D446 OA exam tip for you. Furosemide loses potassium, spironolactone saves potassium, and together they stay in balance. Recall hook. Loop loses, spiro saves. 11. An emergency department nurse is triaging a client who reports the very sudden onset of slurred speech, right-sided facial drooping, and marked weakness in the right arm while eating breakfast. What condition should the nurse suspect first and act on immediately? A. Severe migraine headache. B. Early Parkinson's disease episode. C. Panic attack from stress. D. Acute stroke or cerebrovascular event. Can you guess the answer? Correct answer. D. Acute stroke or cerebrovascular event. Explanation. Option D is correct because the sudden combination of facial droop, arm weakness, and speech trouble matches the fast stroke screen perfectly. Time equals brain tissue, so the nurse must act at once to speed treatment decisions. Option A is incorrect because a severe migraine may cause some neurological symptoms, but sudden one-sided facial droop and arm weakness during eating strongly suggests stroke. Migraine should only be considered after stroke has been clearly ruled out. Option B is incorrect because Parkinson's disease develops gradually over months and years, not suddenly during breakfast. It brings tremor, shuffling gait and rigidity, not sudden facial droop or one-sided weakness. This presentation does not fit. Option C is incorrect because panic attacks can bring tingling, chest tightness and rapid breathing, but never cause one-sided facial droop or true arm weakness. Focal neurological signs always need workup for stroke before attributing to anxiety. Sudden, one-sided and right now, those three words should make you think stroke before anything else. The symptom cluster here, slurred speech, facial droop on one side and arm weakness on one side, maps directly to the fast stroke screen. F for face, A for arm, S for speech. When all three show up at once and hit suddenly, The brain is losing tissue every minute. Ischemic strokes lose around 2 million neurons per minute until blood flow is restored, which is why this cannot wait for a workup or a specialist to wander by. The nurse calls a stroke alert, gets the patient to imaging, and clears the path for clot-busting treatment. Option A, severe migraine, can cause some neurosigns but does not typically produce sudden one-sided weakness and facial droop during breakfast. Option B, Parkinson's disease, builds up gradually over years, not minutes. Option C, panic attack, produces tingling and chest tightness, never true one-sided droop or weakness. Here's a WGU D446 OA exam tip for you. Sudden onset plus one-sided neurological signs equals stroke until proven otherwise. Recall hook. Sudden plus one-sided equals stroke every single time. 12. A community health nurse is teaching a senior centre audience how to spot a stroke quickly using the FAST acronym. One member asks what the letter T stands for in this important public memory tool. What should the nurse explain? A. Tingling of hands. B. Time to call emergency services. C. Temperature of body. D. Tremor of limbs. What do you think is the answer? Correct answer, B. Time to call emergency services. Explanation. Option B is correct because the T in FAST stands for time, meaning call emergency services right away when stroke signs appear. Fast action helps meet tight treatment windows for clot-busting drugs and can save significant brain tissue. Option A is incorrect because tingling of hands is not part of the FAST tool. While tingling can happen with strokes, FAST highlights the most visible warning signs: face, arms and speech, with time triggering action. Option C is incorrect because body temperature is not part of FAST. Fever can complicate stroke care, but does not belong to the screening tool. FAST deliberately keeps things simple, so the public can recognise strokes and act quickly. Option D is incorrect because tremor of limbs is typical of Parkinson's disease, not stroke. Strokes usually cause weakness or complete paralysis on one side, not rhythmic tremor. The T in FAST refers only to time, not to tremor. FAST was built for the public, not for medical professionals, and that is the whole point. The letters spell out face drooping, arm weakness, speech trouble, and time to call 911. Each letter picks out a sign that a regular person can spot in seconds. But the T is the action step, and it is the most important letter of all, because stroke treatment is brutally time-dependent. Clot-busting drugs like tissue plasminogen activator only work within about 4.5 hours from symptom onset, and the sooner they are given, the better the outcome. If someone sees the F, A and S signs but waits an hour to call, the window may close before the patient ever reaches the hospital. Option A, tingling, is not part of FAST, even if it happens sometimes. Option C, body temperature, has nothing to do with stroke screening. Option D, tremor, fits Parkinson's disease, not stroke. Here's a WGU D446 OA exam tip for you. When a FAST question asks about the T, the answer is always time to call for help. Recall hook. T equals time and time is brain. 13. A client arrives at the emergency department with confirmed ischemic stroke symptoms that began about 2 hours ago. The provider considers giving tissue plasminogen activator. What is the main reason this medication must be given within a strict time window? A. It breaks clots but raises bleeding risk. B. It causes severe drowsiness quickly. C. It only works against viral strokes. D. It cures stroke permanently once given. Do you know the answer? Correct answer, A. It breaks clots but raises bleeding risk. Explanation. Option A is correct because tissue plasminogen activator dissolves clots and restores blood flow, but also raises the risk of dangerous bleeding, including hemorrhage in the brain. Giving it within the narrow window balances benefit against that serious risk. Option B is incorrect because drowsiness is not the main concern with tissue plasminogen activator. The critical risk is bleeding, particularly into the brain or internal organs. Sedation is not a major reason for strict timing with this medication. Option C is incorrect because tissue plasminogen activator works on blood clots, not viruses. It dissolves the clot blocking an artery in ischemic strokes. Viral causes of stroke are rare, and antivirals would not fit standard stroke care. Option D is incorrect because tissue plasminogen activator restores blood flow but does not cure stroke permanently. Clients still need rehabilitation, blood pressure control, and secondary prevention. Promising a permanent cure would misstate what this medication does. Tissue plasminogen activator, often called TPA, is powerful medicine and dangerous medicine at the same time. It works by breaking down the fibrin mesh holding a clot together, which reopens the blocked artery and restores blood flow to brain tissue that was about to die. That part is the benefit. The problem is that TPA does not tell the body only dissolve this one clot. It raises bleeding risk everywhere, including old blood vessel weaknesses in the brain that can rupture into a catastrophic hemorrhage. That is why the window is set tight, typically within 3 to 4.5 hours of symptom onset. Give it too late, and the dead brain tissue is already soft and prone to bleeding, turning a rescue into a hemorrhage. The strict timing balances benefit against bleeding. Option B is wrong because drowsiness is not the main concern. Option C is wrong because TPA works on clots, not viruses. Option D is wrong because stroke needs long-term rehabilitation, not a one-shot cure. Here's a WGU D446 OA exam tip for you. On TPA questions, the reason for the tight window is always about balancing clot breakup against bleeding risk. Recall hook. TPA breaks clots but also breaks the seal on bleeds. 14. A client arrives by ambulance after a motor vehicle crash with a suspected high cervical spine injury. The nurse begins the initial priority assessment. Which body system needs the most urgent attention because of how cervical damage typically affects it? A. Digestive system function. B. Skin integrity only. C. Respiratory system airway breathing. D. Hair and nail growth. Do you know the answer? Correct answer, C. Respiratory system airway breathing. Explanation: Option C is correct because high cervical spine injuries can disrupt nerves that control the diaphragm and chest muscles. This puts airway and breathing at immediate risk, so respiratory assessment and potential mechanical ventilation come first in this client. Option A is incorrect because the digestive system can be affected over time from reduced mobility, but it is not the immediate priority after a cervical spine injury. Life-threatening breathing problems must be identified and addressed first. Option B is incorrect because skin care matters long-term for spinal cord injury patients, but it is never the first concern during the initial trauma assessment. Airway, breathing, and circulation always take priority over skin integrity checks. Option D is incorrect because hair and nail growth have no clinical relevance during acute cervical spine injury management. This answer simply does not connect to any actual nursing priority and has no place in trauma assessment. When you hear high cervical spine injury, think breathing before anything else. The nerves that drive the diaphragm come out of the cervical spinal cord at roughly levels C3, C4, and C5. There is even a classic saying, C3, 4, 5 keeps the diaphragm alive. Damage above or at that level can partly or fully cut the brain signal to the diaphragm, which paralyzes the main breathing muscle. Add in damage to the chest wall muscles controlled from lower cervical and upper thoracic levels, and the patient can lose the ability to pull air in at all. That is why the first priority assessment is airway and breathing, and why many high cervical injuries end up needing mechanical ventilation within minutes. Option A, digestive problems, matter later but not immediately. Option B, skin integrity, matters over days and weeks. Option D, hair and nail growth, has no clinical role here. Here's a WGU D446 OA exam tip for you. High cervical injury always points you to respiratory first, because the phrenic nerves control the diaphragm. Recall hook. C345 keeps the diaphragm alive. 15. A client is admitted with a hemorrhagic stroke after experiencing a sudden severe headache, described as the worst pain of their entire life. The nurse reviews the admitting medical orders. Which intervention is clearly contraindicated and should be questioned for this client? A. Strict blood pressure control. B. Neurological checks each hour. C. Elevating head of the bed. D. Tissue plasminogen activator infusion. Can you guess the answer? Correct answer, D. Tissue plasminogen activator infusion. Explanation. Option D is correct because tissue plasminogen activator dissolves clots, which would make bleeding worse in a hemorrhagic stroke. Giving it to a client with brain bleeding would greatly increase death and disability, so it must not be started. Option A is incorrect because strict blood pressure control is actually one of the most important interventions for hemorrhagic stroke. Lowering pressure slows bleeding and protects brain tissue, so this order should be followed rather than questioned. Option B is incorrect because hourly neurological checks are standard and expected in hemorrhagic stroke. Frequent assessment catches increasing intracranial pressure or new deficits early, allowing quick intervention. The nurse should carry out this order. Option C is incorrect because elevating the head of the bed helps drain blood from the brain and lowers intracranial pressure. This intervention is safe and even helpful in hemorrhagic stroke, so it should not be questioned at all. The phrase "worst headache of my life" is a neurological red flag that points straight at a hemorrhagic stroke, usually from a ruptured aneurysm. In a hemorrhagic stroke, a blood vessel in the brain has actually burst, and blood is pouring into brain tissue or the surrounding space. Now look at what tissue plasminogen activator does. It dissolves clots. It thins the blood's ability to clot. Giving a clot buster to someone who is actively bleeding into their brain would pour gasoline on the fire. The hemorrhage would expand, pressure inside the skull would spike, and the patient's survival chances would collapse. That is why TPA is absolutely contraindicated in hemorrhagic stroke and should be questioned immediately. Option A, blood pressure control, actually helps because lower pressure slows bleeding. Option B, hourly neuro checks catch worsening changes early. Option C, elevating the head, lowers intracranial pressure and helps drainage. Here's a WGU D446 OA exam tip for you. In hemorrhagic stroke, never give anything that breaks clots or thins blood. Recall hook. Bleeding brain plus clot buster equals disaster. 16. A nurse assesses a client with a new diagnosis of Graves' disease. The client asks why they have been feeling so warm, nervous and shaky, while also losing weight despite a normal appetite. How should the nurse explain the underlying cause? A. The thyroid gland stopped producing hormone. B. Thyroid gland produces too much hormone. C. The adrenal glands are failing completely. D. The pituitary gland has no function. Do you know the answer? Correct answer, B. Thyroid gland produces too much hormone. Explanation. Option B is correct because Graves' disease is an autoimmune condition that stimulates the thyroid to overproduce thyroid hormone. Excess hormone speeds metabolism, which causes heat intolerance, anxiety, tremor, and weight loss even when food intake stays normal. Option A is incorrect because a thyroid that stops producing hormone describes hypothyroidism, not Graves' disease. Hypothyroid symptoms include cold intolerance, weight gain, and fatigue, which are the exact opposite of what this client reports. Option C is incorrect because adrenal failure causes fatigue, low blood pressure, weight loss, and salt craving, but rarely heat intolerance or tremor. Graves' disease is a thyroid autoimmune disorder, not an adrenal one, which misidentifies the gland. Option D is incorrect because a non-functioning pituitary would cause multiple hormone deficiencies and serious illness, not the typical high metabolism picture of Graves' disease. The pituitary signals the thyroid, but it's not the source of excess hormone. Graves' disease is the body's own immune system attacking the thyroid in a very specific way. Instead of destroying the gland, the antibodies tell it to work harder. They bind to the same receptors that thyroid-stimulating hormone normally uses and push the thyroid into overdrive. The result is an oversupply of thyroid hormone flooding the body, and that hormone drives metabolism everywhere. Heart rate climbs, the body generates extra heat, muscles tremor, weight drops off even with normal eating, and anxiety rises. The client's symptoms read like a textbook list of hyperthyroidism, because that is exactly what is happening. Option A, a thyroid that stops producing hormone, is hypothyroidism, which gives cold intolerance and weight gain, the opposite picture. Option C, adrenal failure causes fatigue and low blood pressure, not heat intolerance and tremor. Option D, non-functioning pituitary, would create multiple hormone failures, not a pattern of excess. Here's a WGU D446 OA exam tip for you. Hot, shaky, losing weight, fast heart rate equals hyperthyroidism. Recall hook. Graves equals gas pedal stuck down. 17. A nurse is caring for a client diagnosed with Cushing disease who presents with a round face, fatty hump between the shoulders, purple abdominal stretch marks, and high blood sugar readings. What hormone imbalance primarily drives this collection of physical changes? A. Low levels of thyroid hormone. B. Too little insulin being produced. C. Excess cortisol circulating in body. D. Low levels of growth hormone. Can you guess the answer? Correct answer, C. Excess cortisol circulating in body. Explanation. Option C is correct because Cushing disease results from excess cortisol, usually from prolonged corticosteroid use or a pituitary tumour. High cortisol causes fat redistribution, thin skin with stretch marks, high blood sugar, and the classic moon face appearance. Option A is incorrect because low thyroid hormone causes hypothyroidism, not Cushing disease. Hyperthyroid clients have weight gain, cold intolerance, and slow heart rate, but not purple stretch marks, moon face, or a buffalo hump. Option B is incorrect because too little insulin describes type 1 diabetes, which can cause high blood sugar but not fat redistribution, stretch marks, or facial changes. Cushing causes high blood sugar through cortisol, not insulin absence. Option D is incorrect because low growth hormone in adults causes reduced muscle mass, fatigue, and central fat gain, but not the full Cushing picture. The combination of purple stretch marks, moon face, and buffalo hump points specifically to cortisol. Cushing disease looks dramatic once you know what to spot. The body is drowning in cortisol, either from long-term steroid medications or a pituitary tumour pumping out ACT that tells the adrenals to overproduce. High cortisol does very predictable things over time. It redistributes body fat, pulling it from the limbs and depositing it in the trunk, face, and upper back. That gives the round moon face and the fatty buffalo hump between the shoulders. Cortisol also thins the skin by breaking down collagen, which is why stretch marks appear purple and wide, particularly across the abdomen. And because cortisol opposes insulin, blood sugar rises sometimes enough to meet criteria for diabetes. Option A, low thyroid hormone, causes weight gain and slow heart rate, but not stretch marks or moon face. Option B, too little insulin, describes type 1 diabetes, which does not cause fat redistribution. Option D, low growth hormone, causes some fat gain but misses the full picture. Here's a WGU D446 OA exam tip for you. Moon face plus buffalo hump plus purple striae equals cortisol excess. Recall hook. Cushing equals cortisol cranked up. 18. A client admitted with a head injury develops decreased urine output, low serum sodium levels, and increasing confusion. The provider diagnoses syndrome of inappropriate antidiuretic hormone. What is the nurse's priority intervention for managing this dangerous fluid and electrolyte imbalance? A. Restrict fluid intake immediately. B. Give extra oral water freely. C. Encourage high sodium meals only. D. Stop all prescribed medications. Do you know the answer? Correct answer. A. Restrict fluid intake immediately. Explanation. Option A is correct because SID causes the body to hold too much water, which dilutes sodium. Fluid restriction raises sodium safely over time. Severe cases may require hypertonic saline, but the first and safest nursing step is limiting intake. Option B is incorrect because giving extra water would worsen the dilutional hyponatremia and push the client towards seizures or coma. SIAD clients already retain too much fluid, so loading more water directly opposes correct management. Option C is incorrect because high sodium meals alone cannot fix SIAD because the underlying problem is water excess, not sodium shortage. Without fluid restriction, added dietary sodium often gets diluted further, and confusion may worsen. Option D is incorrect because stopping all medications without provider orders could harm the client and is outside nursing scope. Some drugs like D-meclocycline actually help SIAD. The nurse should follow the specific CDAH plan. SIAD, the syndrome of inappropriate antidiuretic hormone, means the body is holding on to too much water when it should be letting it go. Antidiuretic hormone normally tells the kidneys to save water when the body is dry. Instead, the signal fires off even though the body is already full of water, so the kidneys keep holding on. The result is fluid overload with diluted sodium, classic dilutional hyponatremia. Low sodium produces confusion, headache, and if it drops fast enough, seizures or coma. The first and safest nursing step is fluid restriction, usually under a litre per day. That allows sodium to rise slowly on its own as the excess water gets processed out. Severe cases may need hypertonic saline, but never as the first move because correcting sodium too fast causes its own brain injury. Option B, free water, would worsen the dilution directly. Option C, high sodium meals alone, does not fix the root problem of water excess. Option D, stopping all medications, is outside nursing scope. Here's a WGU D446 OA exam tip for you. SIAD means too much water, so the first step is always fluid restriction. Recall hook, SIAD equals soaked inside, ditch the hydration. 19. A client who has been taking levothyroxine for goiter suddenly reports heart palpitations, shortness of breath, increased anxiety, and noticeable weight loss over the past 2 weeks. The nurse recognises these new symptoms as concerning. What should be the nurse's next appropriate action? A. Tell the client to drink more water. B. Have client double the daily dose. C. Reassure that these symptoms are normal. D. Notify the provider about excess hormone signs. Do you know the answer? Correct answer. D. Notify the provider about excess hormone signs. Explanation. Option D is correct because palpitations, anxiety, and weight loss in a client on thyroid medication suggest too much thyroid hormone. The provider must be notified so the dose can be adjusted before dangerous complications like thyroid storm develop. Option A is incorrect because drinking more water does not address thyroid hormone excess and can delay needed treatment. These symptoms point to a medication issue, not fluid imbalance, so hydration advice misses the underlying clinical problem. Option B is incorrect because doubling the dose would worsen the already high thyroid hormone level and could trigger thyroid storm, a life-threatening emergency. Dose changes belong to the provider, and the symptoms call for decreasing rather than increasing. Option C is incorrect because reassuring that palpitations, anxiety, and weight loss are normal misses real warning signs of hypothyroidism. These symptoms signal medication excess and require clinical action, not reassurance to protect the client. This patient is showing classic signs of too much thyroid hormone, and the medication cabinet is the most likely source. Levothyroxine is synthetic T4, replacement hormone for an underactive thyroid or a goiter that needs suppression. If the dose is too high, the body behaves exactly as if it had hyperthyroidism on its own. Heart palpitations, anxiety, shortness of breath, weight loss without trying, these are all textbook signs of excess thyroid hormone in the bloodstream. The correct nursing action is to notify the provider so the dose can be reviewed and adjusted, often downward. Ignoring these symptoms risks progression to thyroid storm, a true emergency with fever, arrhythmias, and altered mental status. Option A, drink more water, does nothing for a hormone problem. Option B, double the dose would trigger storm. Option C, reassurance, misses real warning signs of medication toxicity. Here's a WGU D446 OA exam tip for you. On levothyroxine with palpitations and weight loss, always notify the provider. Recall hook, too much thyroid equals too much motor, pull back the gas. 20. A client with severe untreated hypothyroidism enters the emergency department with fever, rapid heart rate, agitation, and altered mental status. The nurse suspects thyroid storm. What class of medication is often given first to rapidly manage the dangerous cardiovascular symptoms? A. Calcium channel blockers. B. Beta blockers such as propranolol. C. Oral antibiotics immediately. D. Antihistamine tablets. Do you know the answer? Correct answer, B. Beta blockers such as propranolol. Explanation. Option B is correct because beta blockers quickly slow the heart rate and reduce tremor, agitation, and anxiety during thyroid storm. While antithyroid medications address the root cause, beta blockers give fast symptom control, protecting the heart from dangerous stress. Option A is incorrect because calcium channel blockers can lower heart rate, but are not the standard first choice for thyroid storm. Beta blockers have specific benefits in blocking the peripheral effects of excess thyroid hormone on the heart. Option C is incorrect because oral antibiotics do not treat thyroid storm because the cause is hormonal, not infectious. If infection triggered the storm, antibiotics might be added, but they are not first line for cardiovascular control here. Option D is incorrect because antihistamines treat allergies and some sleep issues, but they have no role in thyroid storm. Using them in this emergency would delay real treatment and leave cardiovascular effects completely unaddressed. Thyroid storm is what happens when hyperthyroidism spirals into a life-threatening emergency. Fever, racing heart, agitation, altered mental status. This is a full-body firestorm driven by extreme excess thyroid hormone. The fastest danger is the cardiovascular system because a heart rate that high can cause heart failure or fatal arrhythmias within hours. Beta blockers like propranolol handle that side of the crisis quickly. They block the peripheral effects of thyroid hormone on the heart and blood vessels, bringing heart rate down, cutting tremor, and easing agitation within minutes. Antithyroid drugs like methimazole and propylthiouracil also get started, but they work slowly on hormone production and cannot protect the heart fast enough alone. Option A, calcium channel blockers can lower heart rate, but are not first line for thyroid storm. Option C, oral antibiotics, treat infections and have no role in hormonal crisis. Option D, antihistamines, belong to allergy care, not endocrine emergencies. Here's a WGU D446 OA exam tip for you. In thyroid storm, the first medication to calm the heart is always a beta blocker, like propranolol. Recall hook, storm plus racing heart equals beta blocker breaks. 21. A client receiving hemodialysis 3 times weekly has an arteriovenous fistula in the left arm. The nurse is preparing discharge teaching about daily care of this access site. Which specific instruction is most important for this client to follow consistently? A. Avoid blood pressure readings on that arm. B. Keep the arm under heavy blankets daily. C. Massage the site firmly each morning. D. Wear tight sleeves to protect the fistula. What do you think is the answer? Correct answer. A. Avoid blood pressure readings on that arm. Explanation. Option A is correct because blood pressure cuffs and needle sticks on the fistula arm can damage the access, causing clotting, scarring, or bleeding. Protecting the fistula keeps dialysis working, so the arm must stay free of pressure. Option B is incorrect because heavy blankets trap heat, create pressure, and may block blood flow to the fistula. The arm needs normal, unrestricted circulation and temperature, not extra layers that could stop the thrill felt over the access. Option C is incorrect because massaging the fistula firmly can cause trauma, clot formation, or structural damage to the access. Clients should gently check the thrill by lightly touching the area, not vigorously rub or press on the site. Option D is incorrect because tight sleeves restrict blood flow through the fistula and can cause clotting. Clients should wear loose clothing over the access arm so the vein stays open and dialysis needles can be placed easily. Let's talk about why the fistula arm is off limits for anything that squeezes or pokes it. A dialysis fistula is a surgically created connection between an artery and a vein, usually in the forearm, that lets dialysis needles draw large volumes of blood in and out 3 times a week. That connection is fragile in a specific way. It needs steady, unrestricted blood flow to stay open, and any outside pressure can cause the vein to clot, scar, or collapse. A blood pressure cuff inflates hard enough to stop arterial flow for a full minute, which is exactly what you do not want on a fistula. Same goes for IV sticks, drawing labs, or tight jewellery. Lose the fistula, and the patient loses their lifeline for dialysis. Option B traps heat and creates pressure. Option C traumatises the vein directly. Option D cuts circulation just like a cuff would. Here's a WGU D446 OA exam tip for you. On any fistula question, the correct answer almost always involves protecting the arm from pressure, needles, and constriction. Recall hook. Fistula arm equals hands-off arm. 22. A client on peritoneal dialysis reports new cloudy drainage coming back through the catheter, along with abdominal tenderness and a low-grade fever today. Which complication should the nurse suspect first and report to the provider right away for immediate treatment? A. Minor skin rash around catheter. B. Simple allergic reaction to dialysate. C. Peritonitis from catheter contamination. D. Low blood sugar episode. Do you know the answer? Correct answer, C. Peritonitis from catheter contamination. Explanation. Option C is correct because cloudy effluent, abdominal pain, and fever together point strongly to peritonitis, a serious peritoneal dialysis complication. Prompt provider notification, dialysate culture, and antibiotic therapy are needed to prevent sepsis and protect the peritoneal membrane. Option A is incorrect because a small skin rash may show catheter exit site irritation, but does not explain cloudy fluid or abdominal tenderness. The full picture points to infection inside the peritoneum, not a superficial skin issue. Option B is incorrect because allergic reactions to dialysate can cause itching, hives, or breathing trouble, but not cloudy fluid combined with fever and abdominal pain. The symptom pattern here fits infection, not a hypersensitivity response. Option D is incorrect because low blood sugar causes shakiness, sweating, and confusion, not cloudy drainage or fever. While peritoneal dialysis solutions contain glucose, hypoglycemia does not fit this presentation, and red flags point to peritoneal infection. Cloudy fluid coming back out of the peritoneal catheter is the red flag that every dialysis nurse learns to spot instantly. Clean dialysate goes in looking like water, and it should come back looking about the same, maybe slightly yellow tinged from waste. When it comes back cloudy, that cloudiness is actually white blood cells swarming a peritoneal infection. Add abdominal tenderness and fever to that picture, and you have peritonitis, the most common and serious peritoneal dialysis complication. Peritonitis usually comes from poor sterile technique during catheter connections, letting bacteria enter the abdomen through the catheter path. The nurse's job is fast, notify the provider, send the effluent for culture and cell count, and start antibiotics before sepsis sets in. Option A, a skin rash, does not cause cloudy fluid inside. Option B, an allergy, brings itching or hives, not fever and cloudy drainage. Option D, low blood sugar, causes shakiness and sweating, not a peritoneal picture. Here's a WGU D446 OA exam tip for you. Cloudy effluent plus abdominal pain plus fever always equals peritonitis on peritoneal dialysis. Recall hook. Cloudy bag equals cloudy belly. Call now. 23. A client presents with sudden severe flank pain, radiating to the groin, nausea, vomiting and blood in the urine. The nurse suspects a kidney stone. Which patient teaching point is most important for preventing future stone formation after discharge home? A. Drink 1 cup of water daily. B. Eat 3 large meals with salt. C. Avoid all fruits and vegetables. D. Drink plenty of water throughout day. Can you guess the answer? Correct answer. D. Drink plenty of water throughout day. Explanation. Option D is correct because staying well hydrated dilutes urine, which helps prevent minerals from crystallizing into stones. Drinking water throughout the day is the single most effective preventive strategy for most clients with a kidney stone history. Option A is incorrect because drinking only 1 cup of water daily leads to concentrated urine, which sets the perfect stage for stones to form again. Clients at risk need much higher fluid intake to keep minerals dissolved in urine. Option B is incorrect because eating 3 heavy, salty meals adds sodium that can raise calcium in urine and encourage stones. Moderate portions and reduced sodium, along with adequate fluids, actually lower the risk of future stone formation. Option C is incorrect because avoiding all fruits and vegetables is unnecessary and can hurt overall health. Most clients benefit from balanced produce intake. Only specific stone types require limiting certain foods, not complete avoidance. Kidney stones form when minerals in the urine get concentrated enough to crystallize. The single biggest thing that drives that crystallization is not enough fluid. Picture a glass of salt water. If the water is plentiful, salt stays dissolved. Take most of the water away, and the salt starts to clump into crystals at the bottom. The kidneys work the same way. Dilute urine keeps calcium, oxalate, and uric acid dissolved. Concentrated urine lets them bind together and grow into stones that can eventually pass down through the ureter and cause that classic crushing flank pain. The target is usually about 2 to 3 litres of water daily, spread throughout the day, not all at once. Option A, 1 cup daily, is wildly too little and guarantees concentrated urine. Option B, salty meals, pulls calcium into the urine and raises stone risk. Option C, cutting out produce, has no stone prevention benefit and can cause other health issues. Here's a WGU D446 OA exam tip for you. For any kidney stone prevention question, the answer is almost always more water spread across the day. Recall hook. Dilute urine equals dissolved minerals. 24. A client with end-stage renal disease has lab values showing low hemoglobin, elevated phosphorus, and low calcium levels. The provider orders erythropoietin and phosphate binders. Which teaching point correctly explains why these 2 medications work together in this specific case? A. Both medications lower blood sugar quickly. B. They treat anemia and bone disease together. C. They replace all missing kidney functions. D. They only work when taken at night. Can you guess the answer? Correct answer. B. They treat anemia and bone disease together. Explanation. Option B is correct because erythropoietin stimulates red blood cell production to address anemia, while phosphate binders keep phosphorus low to protect bones. Together, they treat two of the most common and dangerous complications seen in end-stage renal disease. Option A is incorrect because neither erythropoietin nor phosphate binders lower blood sugar. These drugs target kidney-related anemia and bone disease, not diabetes. Confusing them with glucose-lowering agents would seriously misguide the client's understanding. Option C is incorrect because these medications help with specific complications, but do not replace full kidney function. Dialysis or transplant are the only real substitutes for kidney work. Saying otherwise gives false confidence in medications alone. Option D is incorrect because timing of administration varies by medication, not by a blanket night-only rule. Phosphate binders should be taken with meals, and erythropoietin is given by injection on a set schedule, unrelated to time of day. End-stage renal disease is not just a filtering problem. The kidneys do several jobs, and when they fail, two specific problems show up almost every time. First, the kidneys normally make erythropoietin, the hormone that tells bone marrow to produce red blood cells. When kidney function drops, erythropoietin production drops with it, and the patient becomes anemic. Synthetic erythropoietin, given by injection, replaces that missing signal and lifts hemoglobin back towards normal. Second, the kidneys normally clear phosphorus from the blood. When they fail, phosphorus builds up, and it pulls calcium out of bones to try to balance. That causes the bones to weaken, a condition called renal osteodystrophy. Phosphate binders taken with meals trap dietary phosphorus in the gut before it ever gets absorbed. So one drug fixes the anemia, and the other protects the bones, and together they cover two of the deadliest renal complications. Option A is wrong because neither drug touches blood sugar. Option C overreaches because only dialysis or transplant replaces full kidney function. Option D invents a night-only rule that does not exist. Here's a WGU D446 OA exam tip for you. Erythropoietin treats anemia, phosphate binders protect bones. Both target failed kidney complications. Recall hook, EPO for blood, binders for bones. 25. A nurse is teaching a client newly diagnosed with glomerulonephritis about dietary changes to slow disease progression and ease kidney symptoms. Which specific dietary approach should the nurse emphasize as most appropriate for managing this particular kidney condition at home? A. Low sodium and low protein intake. B. High sodium with extra salty snacks. C. High protein with daily steak meals. D. Unlimited fluids every hour. Can you guess the answer? Correct answer, A. Low sodium and low protein intake. Explanation: Option A is correct because a low sodium and low protein diet reduces kidney workload and limits fluid retention in glomerulonephritis. Less sodium eases blood pressure, and restricted protein lowers the nitrogen waste that damaged kidneys struggle to filter effectively. Option B is incorrect because high sodium worsens fluid retention, raises blood pressure, and increases stress on already inflamed kidneys. Salty snacks directly oppose the goal of reducing kidney workload in glomerulonephritis and would accelerate disease progression. Option C is incorrect because high protein intake creates more nitrogen waste for the kidneys to clear. Daily steak meals would overwhelm damaged filtering units, raising blood urea nitrogen and pushing the client toward faster kidney decline. Option D is incorrect because unlimited fluids can cause overload in clients with impaired kidneys. Glomerulonephritis patients often need monitored or restricted intake to prevent swelling, high blood pressure, and heart strain from excess fluid. Glomerulonephritis is an inflammatory injury to the tiny filtering units inside the kidney called glomeruli. Those filters are already struggling, so the diet has one goal: give the kidneys less work to do. Sodium is the first target. Sodium pulls water into the bloodstream, raises blood pressure, and makes fluid retention worse. All things an inflamed kidney handles poorly. Cutting salt eases the pressure and the swelling. Protein is the second target. When the body breaks down protein, it produces nitrogen waste, mainly urea, that the kidneys must clear. Damaged glomeruli cannot keep up. So urea builds in the blood and the patient feels sicker. Lower protein intake means less waste to filter. Option B directly raises blood pressure. Option C floods the kidneys with nitrogen waste. Option D overloads failing kidneys. Here's a WGU D446 OA exam tip for you. For any kidney disease diet question, low sodium plus low protein is the default safe answer. Recall hook. Tired kidneys equals lighter menu. 26. A nurse is caring for a client with newly confirmed active tuberculosis on the medical unit. Which type of isolation precautions should the nurse place this client under to best protect other patients, staff and visitors from direct airborne disease transmission? A. Standard contact precautions alone. B. Droplet precautions with surgical mask. C. Airborne precautions with negative pressure. D. No special precautions needed. Can you guess the answer? Correct answer, C. Airborne precautions with negative pressure. Explanation. Option C is correct because active tuberculosis spreads through tiny airborne droplets that stay suspended. Negative pressure rooms pull contaminated air out through filtered systems, and 95 respirators block the small particles that standard masks cannot stop. Option A is incorrect because standard contact precautions protect against surfaces and bodily fluids, not airborne particles. Tuberculosis travels through the air over long distances, so contact alone would leave staff and other patients exposed to inhalation. Option B is incorrect because droplet precautions handle larger respiratory droplets that fall quickly, such as those from influenza. Tuberculosis particles are smaller and stay airborne far longer, so a surgical mask and droplet rules fall short. Option D is incorrect because active tuberculosis is a reportable, communicable disease with serious transmission risk. Skipping precautions would expose everyone on the unit to infection and violate every standard infection control policy in hospital settings. Tuberculosis is the classic airborne infection. And airborne means the bacteria travel on tiny particles that float in room air for hours. That behaviour changes everything about how you isolate the patient. Standard masks and regular patient rooms cannot contain something that hangs in the air. You need two things, a negative pressure room and a 95 respirators for staff. Negative pressure means the room's air pressure is kept lower than the hallway, so when the door opens, air flows into the room, never out of it. That contaminated air then gets pulled through high-efficiency filters before it ever reaches the outside. The N95 is fit-tested to seal against the face and block particles as small as 0.3 microns, which is what you need to stop TB droplet nuclei. Option A, contact only, misses the airborne route entirely. Option B, droplet precautions, stops larger particles that fall quickly. Option D, no precautions, would expose the entire unit. Here's a WGU D446 OA exam tip for you. Active TB always means airborne precautions with negative pressure and N95 respirators. Recall hook. TB floats so air goes in, never out. 27. A client started on 4-drug tuberculosis therapy with rifampin, isoniazid, pyrazinamide, and ethambutol, asks the nurse why so many medications must be taken together. Which response by the nurse best explains the rationale behind the multi-drug approach for this serious infection? A. One drug works but feels stronger combined. B. Multiple drugs prevent bacterial resistance development. C. Each drug treats a separate organ. D. Extra drugs are just for backup. Do you know the answer? Correct answer, B. Multiple drugs prevent bacterial resistance development. Explanation. Option B is correct because tuberculosis bacteria mutate quickly, and single drug therapy allows resistant strains to survive and multiply. Using 4 drugs together attacks the organism through different mechanisms, killing mutants before they can establish drug-resistant colonies. Option A is incorrect because single drug therapy does not simply feel stronger with more added. The science behind multi-drug regimens is resistance prevention, not subjective strength. This answer reflects a basic misunderstanding of antimicrobial pharmacology principles. Option C is incorrect because tuberculosis bacteria grow mainly in the lungs, not scattered across separate organs. Each drug acts on the same organism through a different mechanism, not on different body systems in isolation from each other. Option D is incorrect because these 4 medications are all first-line active agents, not backups. Each plays a specific role in killing actively dividing, slow-growing, or dormant bacteria. None is extra or held in reserve for later treatment failures. 4 drugs at once for tuberculosis sounds like overkill until you know how the organism behaves. TB bacteria mutate fast, and a population of millions almost always includes a few naturally resistant cells. If you throw one drug at them, the susceptible majority dies, and those resistant cells take over. Within weeks, the patient has a drug-resistant infection that is far harder, sometimes impossible, to cure. Hitting the organism with 4 drugs at once, rifampin, isoniazid, pyrazinamide, and ethambutol, each attacking through a different mechanism, overwhelms the population. Any cell resistant to one drug still gets killed by the other 3. That is the core logic. Prevent resistance by attacking from multiple directions simultaneously. Option A is wrong because the science is about resistance, not subjective strength. Option C misreads the biology. Option D calls some drugs backup, but all 4 are first line. Here's a WGU D446 OA exam tip. For you, multi-drug TB therapy is always about preventing drug-resistant strains from emerging. Recall hook. 4 drugs equals 4 ways to kill. No room to mutate. 28. A nurse reviews lab results for a client with HIV infection who has been on antiretroviral therapy for 6 months. The CD4 count has dropped to 180 cells. What does this specific lab finding indicate about the current stage of the client's disease progression? A. Normal immune function and recovery. B. Early HIV exposure without infection. C. Mild viral load reduction only. D. Progression to AIDS diagnosis threshold. Can you guess the answer? Correct answer. D. Progression to AIDS diagnosis threshold. Explanation. Option D is correct because a CD4 count below 200 cells defines AIDS, the most advanced stage of HIV disease. At this level, the immune system can no longer protect against opportunistic infections like pneumocystis to pneumonia or fungal illnesses. Option A is incorrect because normal CD4 counts range from 500 to 1600 cells. A drop to 180 shows significant immune damage, not recovery. Calling this normal would seriously misread the lab and could delay urgent interventions. Option B is incorrect because early HIV exposure without infection would show either no antibodies or a very recent seroconversion. A client already on 6 months of therapy with a falling CD4 count is well past any early exposure stage. Option C is incorrect because viral load and CD4 count measure different things. Viral load tracks the amount of virus, while CD4 tracks immune strength. A low CD4 points to immune failure, not just a viral load change. CD4 cells are the helpers of the immune system, the T lymphocytes that coordinate most defensive responses. HIV specifically targets and destroys these cells, which is why tracking CD4 count tells you how much immune function is left. A healthy CD4 count sits between 500 and 1600. As HIV progresses untreated, the number drops over months to years. The key cutoff to memorize is 200. Once CD4 falls below 200, the diagnosis officially shifts from HIV to AIDS. Regardless of how the patient looks or feels, this number is not arbitrary. Below 200, the immune system cannot fight off organisms that healthy people ignore. Opportunistic infections like pneumocystis pneumonia, oral thrush, and certain cancers start showing up. A count of 180 means this client has crossed that line and meets AIDS criteria. Option A is wrong because normal is much higher. Option B misreads the timeline. Option C confuses CD4 with viral load. Here's a WGU D446 OA exam tip for you. CD4 under 200 always means AIDS diagnosis, no matter what else is happening. Recall hook. Under 200 equals AIDS, period. 29. A nurse admits a client with confirmed COVID-19 infection who has fever, cough, and low oxygen saturation. The client will require supplemental oxygen and close monitoring on the medical unit. Which isolation precautions should the nurse follow while providing direct bedside care for this patient? A. Airborne and contact precautions combined. B. Droplet precautions with surgical mask only. C. Standard precautions with regular gown. D. No special precautions are necessary. What do you think is the answer? Correct answer. A. Airborne and contact precautions combined. Explanation. Option A is correct, because COVID-19 spreads through respiratory droplets and aerosols, especially during procedures. Airborne precautions with an N95 plus contact precautions with gown and gloves give the full protection needed when providing hands-on care at the bedside. Option B is incorrect because a surgical mask blocks large droplets, but not smaller aerosolized particles common in COVID-19 spread. Droplet-only precautions would leave the nurse exposed during coughing, suctioning, or oxygen delivery situations. Option C is incorrect because COVID-19 is a highly contagious respiratory virus that requires more than standard precautions. A regular gown without respiratory protection puts the nurse at real risk during any close patient care activity. Option D is incorrect because COVID-19 requires strict isolation to stop spread within the hospital. Skipping precautions would expose other patients and staff and would directly violate infection control policies used in every accredited facility. COVID-19 spreads through both respiratory droplets and smaller aerosols that can hang in the air, especially during procedures like suctioning, nebulizer treatments, or high-flow oxygen. That means one layer of protection is not enough. You need airborne precautions to block the small aerosols, which means an N95 respirator plus negative pressure when available. And you need contact precautions to block the virus on surfaces, the patient's skin, and any equipment, which means gown and gloves for every room entry. Combined airborne plus contact gives head-to-toe protection for the nurse and stops spread to other patients and staff. Option B, droplet only, misses aerosol exposure. Option C, standard precautions, has no respiratory protection. Option D, no precautions, would spread the virus across the unit. Here's a WGU D446 OA exam tip for you. For COVID care with oxygen or any procedure, combine airborne and contact precautions. Recall hook. COVID equals N95 plus gown, both shields up. 30. A client presents to the clinic with painful grouped vesicles on the lips that began as tingling and burning 2 days ago. The provider diagnoses herpes simplex virus type 1. Which specific teaching point should the nurse emphasize most to prevent spreading the virus to others? A. Antibiotics will cure the outbreak quickly. B. Share lip balm with family freely. C. Avoid direct contact during active outbreaks. D. The virus clears completely after treatment. What do you think is the answer? Correct answer, C. Avoid direct contact during active outbreaks. Explanation. Option C is correct because herpes simplex virus type 1 spreads through direct contact with active lesions, saliva or shared items during outbreaks. Avoiding kissing, oral contact, and shared utensils while vesicles are present greatly reduces transmission to close contacts. Option A is incorrect because antibiotics treat bacterial infections, not viruses. Herpes simplex requires antiviral medications such as acyclovir to shorten outbreaks. Teaching antibiotic use here would mislead the client and delay correct antiviral treatment. Option B is incorrect because shared lip balm can transfer the virus directly from the infected mouth to family members. Sharing personal items that touch active lesions is one of the easiest ways herpes simplex spreads in a household. Option D is incorrect because herpes simplex virus stays in nerve ganglia for life and reactivates under stress, illness, or sun exposure. Antivirals control outbreaks but never eliminate the virus. Telling the client otherwise would create false expectations. Herpes simplex virus type 1 is a lifelong passenger. Once you catch it, the virus hides in nerve ganglia near the face and comes out during stress, illness, sunburn, or fatigue. Outbreaks start with that tingling or burning prodrome, then blister into those painful grouped vesicles on or near the lips. The problem is that these active lesions are packed with virus, and any direct contact with them or with saliva during an outbreak can pass the virus to someone else. Kissing, oral sex, sharing drinks, sharing lip balm, sharing utensils, any skin-to-skin contact with the fluid inside those blisters, all of it transmits. The most effective prevention is simple. No direct contact during outbreaks. Once the lesions crust over and heal, risk drops sharply, though some viral shedding can still happen between outbreaks. Option A is wrong because antibiotics do not touch viruses. Option B transfers the virus directly to family. Option D promises clearance, but the virus stays for life. Here's a WGU D446 OA exam tip for you. For herpes simplex, the biggest prevention teaching is avoid direct contact during active outbreaks. Recall hook. Active sore equals no contact, period. 31. A client diagnosed with gastroesophageal reflux disease reports heartburn, regurgitation, and nighttime coughing that disrupts sleep. The provider recommends lifestyle changes before starting medications. Which specific recommendation should the nurse emphasize as most effective for reducing the client's reflux symptoms at home? A. Eat large meals before bedtime nightly. B. Drink coffee and juice throughout day. C. Lie flat immediately after every meal. D. Elevate head of bed 6 inches. Can you guess the answer? Correct answer, D. Elevate head of bed 6 inches. Explanation. Option D is correct because raising the head of the bed 6 inches uses gravity to keep stomach acid from flowing up into the esophagus during sleep. This simple change greatly reduces nighttime reflux, coughing, and the risk of aspiration. Option A is incorrect because eating large meals before bed fills the stomach right before lying down, pushing acid into the esophagus. Late heavy meals are one of the strongest triggers for nighttime reflux symptoms and should be avoided. Option B is incorrect because coffee and acidic juices relax the lower esophageal sphincter and raise stomach acid production. Drinking these throughout the day would worsen reflux symptoms rather than ease them in any meaningful way. Option C is incorrect because lying flat after meals lets gravity work against digestion, allowing acid to flow back into the esophagus. Clients with reflux should stay upright at least 2 to 3 hours after eating any meal. GERD happens when the lower esophageal sphincter, the valve between the stomach and the esophagus, does not close tightly enough. Stomach acid then washes back up into the esophagus, burning the lining and causing heartburn, regurgitation, and that nighttime cough when acid sneaks into the airway. Gravity is your simplest weapon. Raising the head of the bed by about 6 inches tilts the whole torso upward, so during sleep, acid has to work against gravity to reach the esophagus. That one change can make the difference between a sleepless night of coughing and a full night of rest. Using extra pillows does not work the same way because pillows bend the neck without raising the torso. Blocks under the bed frame or a wedge pillow under the shoulders are the right tools. Option A fills the stomach and triggers reflux. Option B relaxes the sphincter. Option C removes gravity's help. Here's a WGU D446 OA exam tip for you. GERD questions about sleep or nighttime symptoms almost always point to elevating the head of the bed. Recall hook. Gravity beats acid, tilt the bed up. 32. A client prescribed omeprazole, a proton pump inhibitor, for gastroesophageal reflux disease, asks the nurse how to take the medication for the best results. Which specific timing and administration instruction should the nurse provide to maximize the drug's therapeutic effect on reflux symptoms? A. Take 30 minutes before first meal. B. Take only when heartburn symptoms occur. C. Take with antacids at the same time. D. Take at bedtime on a full stomach. Do you know the answer? Correct answer: A. Take 30 minutes before first meal. Explanation: Option A is correct, because proton pump inhibitors, like omeprazole, work best when taken 30 minutes before the first meal of the day. This timing lets the drug block active acid pumps when they are most stimulated by eating. Option B is incorrect, because proton pump inhibitors need daily scheduled dosing to build therapeutic levels and keep acid suppressed. Taking them only during heartburn acts like a short-acting antacid and misses the preventive mechanism entirely. Option C is incorrect, because antacids can interfere with proton pump inhibitor absorption when taken at the same time. Spacing them apart preserves the full effect of each medication and avoids reduced acid blocking benefit. Option D is incorrect, because bedtime dosing on a full stomach fails to target active acid pumps before peak food-stimulated secretion. A morning dose before breakfast gives the strongest suppression across the entire day. Omeprazole belongs to a class called proton pump inhibitors, and the name tells you exactly how they work. Proton pumps are the pumps in the stomach lining that push hydrogen ions into the stomach to make acid. These pumps are most active right before and during meals, when the stomach expects food. Omeprazole blocks these pumps, but only the ones that are currently active. That is the trick. Take the drug 30 minutes before breakfast, and by the time the patient takes the first bite, the drug has circulated to the stomach and is waiting to catch every pump as food activation kicks in. Take it at a random time or with a full stomach, and the pumps are already done firing, and the drug misses them. Take it only when symptoms flare, and you never build the steady blockade that prevents reflux damage. Option B acts like an antacid. Option C reduces absorption. Option D misses the morning peak. Here's a WGU D446 OA exam tip for you. Any proton pump inhibitor is best given 30 minutes before the first meal of the day. Recall hook, PPI before the pumps wake up. 33. A nurse provides dietary teaching to a client newly diagnosed with diverticulosis who wants to prevent flare-ups and bowel complications at home. The client asks what foods to add to the daily meal plan. Which specific dietary approach should the nurse emphasize as most appropriate here? A. Low-fiber white bread and pasta. B. High-fiber fruits, vegetables and whole grains. C. High-fat red meat and fried foods. D. Only liquid diet at every meal. Do you know the answer? Correct answer: B. High-fiber fruits, vegetables and whole grains. Explanation: Option B is correct, because high-fiber foods add bulk to stool and keep the bowel moving regularly, which reduces pressure in the colon wall. This pressure reduction prevents new diverticula from forming and keeps existing pouches from becoming inflamed. Option A is incorrect, because low-fiber foods like white bread and pasta slow bowel movement and increase colon pressure. This raises the risk of diverticular pouches forming and becoming inflamed, directly opposing the treatment goal. Option C is incorrect, because high-fat red meat and fried foods lack fibre and slow digestion. These foods promote constipation and pressure buildup in the colon, which worsens diverticular disease over time rather than helping control it. Option D is incorrect, because a liquid-only diet is used temporarily during acute diverticulitis flare-ups, not for long-term diverticulosis prevention. Once healed, clients need solid high-fiber meals to keep the bowel functioning properly each day. Diverticulosis is when small pouches called diverticula develop in the wall of the colon. Those pouches form from years of high pressure inside the bowel, which pushes the lining outward through weak spots in the muscle wall. The root cause of that high pressure is usually chronic constipation from a low-fiber diet. Fiber is the fix. Fiber soaks up water, bulks up the stool, and keeps things moving through the colon smoothly. A bulky, soft stool means less pressure, less straining, and less chance of new pouches forming or existing ones getting inflamed. The daily target for most adults is 25 to 35 grams of fiber spread across fruits, vegetables, legumes, and whole grains. Water intake has to come up too, because fiber without enough fluid just sits and causes its own blockage. Option A promotes constipation. Option C lacks fiber entirely. Option D is only for acute flares. Here's a WGU D446 OA exam tip for you. For chronic diverticulosis, always pick high fiber plus adequate fluids. Recall hook. High fiber equals low colon pressure. 34. A client with end-stage liver failure shows confusion, tremors, and a sweet breath odour. The provider orders lactulose. Which specific physiological effect of lactulose makes it the best choice for treating hepatic encephalopathy in this client with advanced liver disease? A. Replaces missing liver enzymes directly. B. Boosts red blood cell production. C. Traps ammonia and eliminates it. D. Raises blood pressure rapidly. What do you think is the answer? Correct answer, C. Traps ammonia and eliminates it. Explanation. Option C is correct because lactulose lowers bowel pH, which traps ammonia as ammonium, and pulls it into the colon for elimination through stool. Removing ammonia directly treats the confusion and neurological symptoms seen in hepatic encephalopathy. Option A is incorrect because lactulose does not replace liver enzymes. The medication works inside the gut to trap and remove ammonia, not inside the liver to boost enzyme function. Enzyme replacement is not part of its action. Option B is incorrect because lactulose has no effect on red blood cell production. Anemia in liver disease comes from other causes such as bleeding or poor nutrition. Lactulose targets ammonia removal, not blood cell formation. Option D is incorrect because lactulose has no direct blood pressure effect. Clients with liver failure often have low blood pressure from fluid shifts, and lactulose does not raise or address this issue. Its job is waste elimination. Hepatic encephalopathy is one of the strangest sounding complications of liver failure, but the mechanism is actually simple. Protein metabolism produces ammonia as a waste product. A healthy liver converts ammonia into urea, which the kidneys then excrete. In liver failure, the liver cannot keep up, so ammonia builds up in the bloodstream. Lactulose is the treatment, and it works in a clever way. It is a non-absorbable sugar that reaches the colon intact. Bacteria there ferment it, which lowers the pH of the bowel. In that acidic environment, ammonia in the blood converts to ammonium, which cannot cross back into circulation. The ammonium gets trapped in the stool and leaves the body with the next bowel movement. That's why lactulose also acts as a laxative. The stooling is part of the treatment. Option A is wrong because lactulose does not replace enzymes. Option B has no effect on red blood cells. Option D does not touch blood pressure. Here's a WGU D446 OA exam tip for you. Lactulose traps ammonia in the gut and pulls it out with stool. Recall hook. Lactulose equals ammonia trapdoor. 35. A client with chronic pancreatitis reports greasy, foul-smelling stools, weight loss, and abdominal discomfort after eating. The provider prescribes pancreatic enzyme replacement therapy. Which teaching point should the nurse emphasize most about timing and administration of these specific enzyme medications for best results? A. Take enzymes only at bedtime nightly. B. Take enzymes 2 hours after meals. C. Mix enzymes into very hot foods. D. Take enzymes with every meal and snack. Do you know the answer? Correct answer, D. Take enzymes with every meal and snack. Explanation. Option D is correct because pancreatic enzymes must be taken with every meal and snack to help digest fats, proteins, and carbohydrates as food enters the intestine. Taking them outside of meals wastes the medication since no food is present. Option A is incorrect because bedtime-only dosing completely misses the actual meal times when digestion is happening. Without enzymes present during meals, fats and nutrients pass through undigested, leading to greasy stools and continued weight loss. Option B is incorrect because enzymes taken 2 hours after meals arrive too late to digest that food. The food has already moved past the small intestine where enzymes work, so the therapy provides no benefit for that meal. Option C is incorrect because hot foods inactivate the enzyme coating and destroy drug activity. Pancreatic enzymes must be swallowed whole or sprinkled on cool foods such as applesauce to keep the medication effective for digestion. In chronic pancreatitis, the pancreas has been damaged enough that it no longer secretes enough digestive enzymes to break down food. Fats, proteins, and carbohydrates pass through the gut mostly intact, which produces greasy, foul-smelling stools called steatorrhea, along with weight loss and nutritional deficiencies. Pancreatic enzyme replacement therapy, often pancrelipase, is the fix. The medication contains the same enzymes the pancreas would normally make: lipase for fats, protease for proteins, amylase for carbohydrates. The critical point is timing. These enzymes only work on food that is currently in the small intestine. Take them with every meal and snack, and they reach the intestine at the same time the food does and digest it properly. Skip that timing, and the food passes through without being broken down. Also, they are given in enteric-coated capsules to protect the enzymes from stomach acid. Patients should swallow them whole or open them onto cold, soft food, like applesauce, never hot food, which destroys the coating. Option A misses every meal. Option B arrives too late. Option C inactivates the drug. Here's a WGU D446 OA exam tip. For you, pancreatic enzymes must be given with every meal and every snack, no exceptions. Recall hook. Food in equals enzymes in. 36. A nurse is assessing a client with type 1 diabetes who took morning insulin and then skipped breakfast to rush to an appointment. The client now feels shaky, sweaty, and confused. Which specific clinical finding best confirms the nurse's suspicion of low blood sugar in this client? A. Blood glucose below 70. B. Blood glucose above 300. C. High ketones in the urine. D. Fever with a rapid respiratory rate. Do you know the answer? Correct answer, A. Blood glucose below 70. Explanation. Option A is correct because hyperglycemia is defined as a blood glucose reading below 70 milligrams per deciliter. Shakiness, sweating, and confusion are classic symptoms, and the blood glucose value confirms the diagnosis and guides the nurse's immediate treatment choice. Option B is incorrect because a blood glucose above 300 shows hyperglycemia, not low blood sugar. The symptoms of high blood sugar are different and include excessive thirst, frequent urination, and fruity breath, rather than shakiness and sweating. Option C is incorrect because high urine ketones signal diabetic ketoacidosis, which stems from very high blood sugar with no insulin effect. This condition shows different symptoms such as deep breathing and fruity breath, not the shakiness seen here. Option D is incorrect because fever with fast breathing points to infection or acidosis, not hypoglycemia. Low blood sugar does not cause fever. The nurse should match symptoms to lab values to choose the correct intervention and avoid delay. This patient gives you the classic setup for hypoglycemia. Morning insulin was taken, which drops blood sugar, but Breakfast never happened, which means no glucose came in to balance the insulin. Within an hour or two, blood sugar plummets. The shakiness, sweating, and confusion are all signs of the body's emergency response. Low glucose starves the brain, and the adrenal glands dump out epinephrine to try to raise sugar fast, which is what causes the shakiness and sweating. Confusion comes from the brain itself running low on fuel. The definition of hyperglycemia is a blood glucose value below 70 milligrams per deciliter. That value, paired with the symptoms, confirms the diagnosis and triggers the rule of 15 grams of fast-acting carbohydrate. Wait 15 minutes. Recheck. Option B is hyperglycemia. Option C points to diabetic ketoacidosis. Option D points to infection. Here's a WGU D446 OA exam tip for you. Anytime you see shaky, sweaty, and confused on insulin, check blood glucose for a reading under 70. Recall hook, shaky plus sweaty equals sugar under 70. 37. A client newly diagnosed with type 2 diabetes receives a prescription for regular short-acting insulin before each meal. The client asks the nurse when this insulin will peak after injection. Which specific time window should the nurse teach as the expected peak action for regular insulin? A. 15 to 30 minutes after dose. B. Around 12 hours after injection. C. 2 to 4 hours after dose. D. 24 hours after injection. Can you guess the answer? Correct answer, C. 2 to 4 hours after dose. Explanation. Option C is correct because regular short-acting insulin peaks 2 to 4 hours after subcutaneous injection. Clients must eat within 30 minutes of the dose and expect the strongest effect at this peak window to avoid hypoglycemia between meals. Option A is incorrect because 15 to 30 minutes describes rapid-acting insulins like Lispro or Aspart, not regular insulin. Mixing up these timing windows can lead to serious hypoglycemia if meals are not matched to the correct insulin. Option B is incorrect because 12 hours fits NPH intermediate-acting insulin, not regular short-acting. Teaching a client the wrong peak time could cause missed meals during the true peak and dangerous drops in blood sugar later in the day. Option D is incorrect because 24 hours describes long-acting basal insulins such as glargine. These drugs have no true peak and work across the day. Confusing basal with short-acting insulin creates risk of both hyperglycemia and hypoglycemia. Insulin timing is one of those topics where mixing up the numbers can hurt someone, so let's lock in each type. Regular insulin is short-acting. After a subcutaneous injection, it starts working in about 30 minutes, peaks between 2 and 4 hours, and wears off around 6 to 8 hours. The peak window is what matters for safety. At peak, blood sugar is being pulled hardest into cells, so if the patient has not eaten, that is when hypoglycemia strikes. Teaching is straightforward. Eat within 30 minutes of the dose, expect the strongest effect between 2 and 4 hours after, and plan meals and snacks so the peak is covered. Option A, 15 to 30 minutes, describes rapid-acting insulins like Lispro and Aspart. Option B, 12 hours, fits NPH, an intermediate-acting insulin. Option D, 24 hours, describes long-acting basal insulins like glargine, which have no pronounced peak. Here's a WGU D446 OA exam tip for you. Regular short-acting insulin peaks in 2 to 4 hours, and the patient must have food available during that window. Recall hook. Regular equals 2 to 4. Plan a meal. 38. A client with type 1 diabetes arrives at the emergency department with deep, rapid breathing, fruity breath odour, and a blood glucose of 480. Labs show ketones and low bicarbonate. Which specific treatment priority should the nurse prepare to deliver first for this life-threatening diabetic emergency? A. Oral glucose tablets and juice. B. Subcutaneous long-acting basal insulin. C. Rest with no IV fluid therapy. D. IV fluids followed by insulin drip. Do you know the answer? Correct answer, D. IV fluids followed by insulin drip. Explanation? Option D is correct because diabetic ketoacidosis treatment starts with IV fluid resuscitation to correct severe dehydration, then insulin by continuous drip to lower glucose gradually. This order prevents dangerous fluid shifts and brain swelling during blood sugar correction. Option A is incorrect because oral glucose treats hypoglycemia, not ketoacidosis. This client has dangerously high blood sugar, and adding glucose would worsen the condition and delay the life-saving insulin and fluid replacement needed right now. Option B is incorrect because subcutaneous basal insulin works too slowly and unpredictably during diabetic ketoacidosis. Emergency care calls for IV insulin that allows tight control and gradual glucose reduction, matched with ongoing fluid and electrolyte monitoring. Option C is incorrect because rest without IV fluids allows severe dehydration and acidosis to worsen rapidly. Diabetic ketoacidosis is a medical emergency that requires aggressive IV treatment, not passive observation. Delay can quickly become fatal. Diabetic ketoacidosis is a three-part crisis: severe hyperglycemia, dehydration, and acidosis from ketone buildup. The patient is so dehydrated that circulation is failing and the blood pH is dangerously low. The order of treatment matters a lot because doing the right things in the wrong sequence can actually make things worse. Step 1 is IV fluids, usually normal saline, to restore circulating volume and get perfusion back to the kidneys and brain. Dehydration alone will drop the glucose sum, just by diluting it. Step 2 is the insulin drip, a continuous IV infusion, started only after fluid resuscitation is well underway. Insulin is titrated carefully, so glucose falls no faster than 50 to 100 milligrams per deciliter per hour. If you drop glucose too fast, water rushes back into brain cells and causes cerebral edema. Option A treats hypoglycemia. Option B absorbs too slowly. Option C lets the patient crash. Here's a WGU D446 OA exam tip for you. In DKA, always start with IV fluids first, then start the insulin drip. Recall hook: fluid fills the tank, insulin follows. 39. A client recently started on lisinopril, an ACE inhibitor, for newly diagnosed hypertension returns to the clinic, complaining of a persistent dry cough that keeps them awake at night. Which nursing action best addresses this common and known specific side effect of ACE inhibitor therapy? A. Notify provider about common ACE cough. B. Tell client the cough is normal. C. Stop the drug without calling anyone. D. Double the dose to fix symptoms. Do you know the answer? Correct answer: A. Notify provider about common ACE cough. Explanation: Option A is correct because a persistent dry cough is a well-known side effect of ACE inhibitors caused by bradykinin buildup. The provider can switch the client to an angiotensin receptor blocker, which treats blood pressure without causing this cough. Option B is incorrect because the cough is expected with ACE inhibitors, but should not simply be tolerated. Telling the client to live with sleep-disrupting symptoms ignores a clear path to a medication that works without this side effect. Option C is incorrect because stopping blood pressure medication without provider consultation risks rebound hypertension, stroke, or cardiac events. Any change to antihypertensive therapy must be made by the provider, not through unsupervised self-management by the client. Option D is incorrect because doubling the dose raises the ACE inhibitor level and worsens side effects such as cough, hyperkalemia, and kidney impact. Increasing the dose never fixes a cough that comes from the drug class itself. ACE inhibitors like lisinopril work by blocking angiotensin-converting enzyme, which lowers blood pressure effectively. The catch is that the same enzyme also breaks down bradykinin, a compound that irritates airway tissues. When the ACE enzyme is blocked, bradykinin accumulates in the lungs and respiratory tract, producing that persistent, dry, tickling cough about 10% of patients develop. The cough is not dangerous, but it is miserable, especially at night, and it often makes patients stop taking the medication on their own. The right action is to notify the provider so the medication can be switched, usually to an angiotensin receptor blocker ending in the suffix sartan, like losartan or valsartan. ARBs lower blood pressure through a similar pathway, but do not mess with bradykinin, so they produce no cough. Option B misses a fixable problem and risks non-adherence. Option C can trigger rebound hypertension. Option D worsens the side effect. Here's a WGU D446 OA exam tip for you. ACE inhibitor cough means notify the provider and expect to switch to an ARB. Recall hook. ACE coughs, ARB does not. 40. A nurse is teaching a newly diagnosed hypertensive client about lifestyle changes to help lower blood pressure before starting any medications. The client asks what changes make the biggest difference. Which specific lifestyle modification should the nurse emphasize as most effective for lowering blood pressure? A. Eat a high-sodium daily diet. B. Reduce sodium and increase physical activity. C. Drink sugary sodas with every meal. D. Smoke cigarettes to relax blood vessels. Can you guess the answer? Correct answer, B. Reduce sodium and increase physical activity. Explanation. Option B is correct because reducing sodium intake and adding regular physical activity are the two most effective non-drug steps for lowering blood pressure. Low sodium eating eases fluid retention, while exercise strengthens the heart and improves vascular flexibility over time. Option A is incorrect because high sodium intake pulls water into the bloodstream and directly raises blood pressure. Clients with hypertension are told to keep sodium under 1,500 to 2,300 milligrams each day to control readings. Option C is incorrect because sugary sodas add empty calories, promote weight gain, and worsen metabolic health. Weight gain and insulin resistance both raise blood pressure, so adding sodas to daily meals moves the client in the wrong direction. Option D is incorrect because smoking damages blood vessel walls and makes blood pressure readings climb. Nicotine causes vasoconstriction, not relaxation, and also raises stroke and heart attack risk. This advice would be outright harmful. Before reaching for medications, clinicians usually try to see how far lifestyle alone can lower blood pressure, and two changes do the heaviest lifting. First, cutting sodium. Sodium pulls water into the bloodstream, which raises blood volume and blood pressure directly. Most adults with hypertension are told to keep sodium under 1,500 to 2,300 milligrams a day, which means skipping processed foods, canned soups, deli meats, and most restaurant meals. Second, physical activity. Regular aerobic exercise, about 150 minutes a week of moderate intensity, strengthens the heart so it pumps more efficiently and relaxes blood vessels over time. Together, these two changes can drop systolic blood pressure by 10 to 15 points, enough to keep many patients off medication entirely. Option A directly raises blood pressure. Option C drives weight gain and insulin resistance. Option D constricts vessels and damages their lining. Here's a WGUD 446 OA exam tip for you. For hypertension lifestyle questions, the best answer pairs low sodium with regular physical activity. Recall hook. Less salt plus more movement equals lower pressure. 41. A nurse is teaching a client newly diagnosed with systemic lupus erythematosus about triggers that can cause flares and skin involvement. The client asks what daily activity changes matter most. Which specific protective measure should the nurse emphasize as most effective for preventing lupus skin flares at home? A. Spend all day in direct sun. B. Skip all hats and long sleeves. C. Wear sunscreen and protective clothing outdoors. D. Tanning beds weekly to build resistance. Do you know the answer? Correct answer, C. Wear sunscreen and protective clothing outdoors. Explanation. Option C is correct because ultraviolet light triggers lupus flares by activating skin immune cells and causing the classic butterfly rash and joint symptoms. Wearing broad-spectrum sunscreen and protective clothing outdoors prevents these triggers and keeps the disease better controlled. Option A is incorrect because direct sun exposure is the single biggest skin trigger for lupus flares. Telling a client to spend all day outdoors unprotected would cause the rash and joint pain to return or worsen quickly. Option B is incorrect because hats and long sleeves are part of the protective clothing clients need. Skipping them exposes more skin to ultraviolet light, which drives flares and damages tissue over time in people with lupus. Option D is incorrect because tanning beds deliver concentrated ultraviolet light that causes severe lupus flares. No level of tanning builds resistance in autoimmune disease. This practice would be directly harmful and must never be recommended. Lupus is an autoimmune disease where the body's immune system mistakenly attacks its own tissues. And ultraviolet light is one of the biggest outside triggers for flares. Here's why. When UV light hits skin cells in a person with lupus, it damages cellular DNA and causes those cells to release fragments into the bloodstream. The confused immune system sees those fragments as foreign and mounts an attack, which produces the classic butterfly rash across the cheeks, joint pain, fatigue, and sometimes organ inflammation. That's why sun protection is not a nice to have in lupus. It is frontline disease management. Broad-spectrum sunscreen blocks both UVA and UVB, and SPF 30 or higher is the usual target. Wide-brimmed hats, long sleeves and UV protective clothing cover the rest. Patients avoid peak sun hours, usually 10 in the morning to 4 in the afternoon, whenever possible. Option A is the biggest possible trigger. Option B removes physical protection. Option D delivers concentrated UV that flares the disease badly. Here's a WGU D446 OA exam tip for you. For any lupus teaching question, sun protection is almost always the right answer. Recall hook. UV equals fuel for lupus, block it. 42. A client diagnosed with Raynaud's phenomenon reports that fingers turn white and then blue when exposed to cold weather or emotional stress. The client works outdoors in winter months. Which specific teaching point should the nurse emphasize most for preventing painful Raynaud attacks in cold weather? A. Soak hands in ice water daily. B. Skip gloves to toughen fingers. C. Smoke cigarettes to warm up quickly. D. Wear warm gloves and dress in layers. Do you know the answer? Correct answer, D. Wear warm gloves and dress in layers. Explanation? Option D is correct because Raynaud's attacks happen when blood vessels in the fingers and toes narrow sharply during cold exposure. Warm gloves, layered clothing, and avoiding cold objects protect circulation and prevent the colour changes, numbness and pain. Option A is incorrect because soaking hands in ice water is the strongest possible Raynaud trigger. The extreme cold would cause vessels to clamp shut immediately, producing a painful attack and possibly tissue damage to the fingertips. Option B is incorrect because skipping gloves exposes the hands to the exact trigger that causes attacks. Fingers would not toughen up to cold, and repeated exposure without protection raises risk of prolonged spasms and skin damage. Option C is incorrect because smoking causes vasoconstriction, which narrows blood vessels even further in Raynaud's. Nicotine directly opposes the goal of keeping peripheral circulation open and would worsen every attack rather than relieve any symptoms. Raynaud's phenomenon is a blood vessel overreaction, not a disease of the fingers themselves. When cold or stress hits, the small arteries in the fingers and toes clamp down far harder than they should. Blood flow drops sharply, which is why the fingers turn white first, that is the blanching from lost circulation. Then they turn blue as the remaining blood loses oxygen, and finally red when the vessels relax and blood rushes back in. The whole attack can last minutes to an hour. The trick to preventing attacks is not letting the trigger reach the fingers in the first place. Warm gloves, not thin ones, keep the hand temperature up. Layered clothing traps body heat and keeps the whole body warmer because cold anywhere on the body can trigger peripheral vasospasm. Hand warmers, mittens over gloves for severe cold, and avoiding iced drinks or frozen food handling all help too. Option A, ice water, is the strongest trigger possible. Option B invites attacks. Option C constricts vessels further through nicotine. Here's a WGU D446 OA exam tip for you. Raynaud's prevention is always about keeping the whole body warm, not just the hands. Recall hook. Cold triggers clamp, warmth keeps vessels open. 43. A client with peripheral arterial disease in the lower legs reports aching pain when walking that stops with rest. The client asks the nurse about the best leg position for easing discomfort during rest. Which specific leg positioning should the nurse recommend for this particular circulation problem? A. Dangle legs downward below heart. B. Keep legs raised above the chest. C. Cross legs tightly while sitting. D. Wrap legs in tight elastic bandages. Can you guess the answer? Correct answer, A. Dangle legs downward below heart. Explanation. Option A is correct because peripheral arterial disease reduces blood flow into the legs, so dangling the legs below heart level uses gravity to improve arterial delivery. This eases aching and supports tissue oxygen delivery during rest periods at home. Option B is incorrect because raising legs above the chest is the correct position for venous insufficiency, not arterial disease. Elevating legs in peripheral arterial disease actually reduces arterial blood flow further and worsens aching and tissue ischemia. Option C is incorrect because crossing legs compresses arteries behind the knee and reduces blood flow to the lower leg. Clients with circulation problems must avoid positions that pinch or squeeze vessels during sitting or resting periods. Option D is incorrect because tight elastic wraps restrict arterial blood flow and can cause serious ischemic damage in peripheral arterial disease. Compression bandages are used for venous problems, not arterial, and would be actively dangerous here. This is one of the trickiest positioning questions on the exam because it feels backwards. For most leg problems, you elevate. For peripheral arterial disease, you do the opposite, you dangle. Here is the reasoning. Peripheral arterial disease means the arteries bringing blood down into the legs are narrowed, usually by atherosclerosis. Arterial blood has to fight against gravity to reach the feet. When the patient rests with legs elevated, gravity pulls blood away from the feet, making ischemia worse and producing that aching pain. When the patient dangles the legs below heart level, gravity helps arterial blood flow down into the feet, easing pain and delivering oxygen. Compare this to venous insufficiency, where the veins cannot pump blood back up. For venous problems, elevation works because it helps blood drain back. PAD is arterial, so it flips the rule. Option B actually worsens arterial pain. Option C pinches arteries behind the knee. Option D restricts arterial inflow and can cause tissue damage. Here's a WGU D446 OA exam tip for you. PAD equals dangle, venous insufficiency equals elevate. Do not mix them up. Recall hook, arterial down, venous up. 44. A client with a history of repeated gout attacks affecting the big toe is started on allopurinol for long-term management and prevention. The client asks how this medication works differently from pain relievers. Which specific mechanism should the nurse explain for this gout maintenance therapy? A. Blocks pain receptors in the joint. B. Thins the blood to flush crystals. C. Lowers uric acid production in body. D. Dissolves crystals by heating the joint. Do you know the answer? Correct answer, C. Lowers uric acid production in body. Explanation. Option C is correct because allopurinol blocks the enzyme that makes uric acid, lowering blood uric acid levels over time. With less uric acid in circulation, fewer crystals form in joints, which prevents the painful inflammatory attacks of gout. Option A is incorrect because allopurinol is not an analgesic and does not block pain receptors. Pain during acute gout is treated with NSAIDs or colchicine, while allopurinol works upstream to prevent crystal formation in the first place. Option B is incorrect because allopurinol is not a blood thinner. Thinning blood has no effect on uric acid crystals deposited in joints. Crystals are removed only by lowering uric acid levels, so they slowly dissolve over time. Option D is incorrect because allopurinol does not heat joints or dissolve crystals directly by any temperature mechanism. The drug acts by blocking an enzyme, which gradually reduces uric acid and allows crystal deposits to shrink naturally. Gout looks like an inflammatory joint disease, but underneath it is a chemistry problem. The body produces too much uric acid, or the kidneys cannot clear enough of it, so uric acid builds up in the blood. Once levels get high enough, uric acid crystallizes into sharp needle-like deposits in joints, most often the big toe. Allopurinol is a maintenance drug, not a flare drug. It blocks xanthine oxidase, the enzyme that makes uric acid in the first place. Less enzyme activity means less uric acid produced, which means lower blood levels over weeks to months. Existing crystals in joints slowly dissolve as levels drop, and new crystals stop forming. It is a long game, not a quick fix. Acute attacks still need NSAIDs or colchicine for pain and inflammation. Option A is wrong because allopurinol is not a pain blocker. Option B is wrong because it is not a blood thinner. Option D is invented. Here's a WGU D446 OA exam tip for you. Allopurinol lowers uric acid production, preventing future gout attacks over time. Recall hook. Allopurinol equals less acid, fewer crystals. 45. A client with rheumatoid arthritis is started on methotrexate, a disease-modifying anti-rheumatic drug, taken once weekly. The client asks the nurse about daily supplements needed with this medication. Which specific supplement should the nurse teach the client to take, along with methotrexate to prevent common side effects? A. Calcium twice a day at bedtime. B. Iron with every single meal daily. C. Vitamin D only in winter months. D. Folic acid to prevent drug side effects. Can you guess the answer? Correct answer, D. Folic acid to prevent drug side effects. Explanation. Option D is correct because methotrexate blocks folate metabolism, which can cause mouth sores, nausea, and bone marrow issues. Daily folic acid supplementation reduces these side effects without lowering the drug's effect on rheumatoid arthritis, joint inflammation. Option A is incorrect because calcium is not the supplement tied to methotrexate side effects. Calcium helps bone health generally, but does not address the folate blocking action of methotrexate that causes the specific side effects seen with this drug. Option B is incorrect because iron is used for anemia from blood loss or deficiency, not for methotrexate. Taking iron daily offers no protection against the mouth sores, nausea, or marrow suppression caused by folate blockade from this drug. Option C is incorrect because vitamin D supports bone health and calcium absorption, but does not counter methotrexate side effects. Seasonal dosing is sometimes used for deficiency, but has no role in protecting against the drug's specific toxicity profile. Methotrexate is one of the most effective disease-modifying drugs for rheumatoid arthritis, but it comes with a predictable set of side effects because of how it works. The drug blocks an enzyme called dihydrofolate reductase, which the body needs to use folate. Folate, also called folic acid, is a B vitamin critical for making new DNA, dividing cells and building red blood cells. When methotrexate blocks folate metabolism, cells that divide quickly get hit first: the lining of the mouth, which leads to mouth sores, the gut, which leads to nausea, and the bone marrow, which can suppress blood cell production. The fix is clean, give extra folic acid. Folic acid supplementation does not interfere with methotrexate's effect on the inflamed joints, but it restores folate availability for the normal tissues that need it. The result is far fewer side effects. Option A, calcium, helps bones but does nothing here. Option B, iron, treats a different kind of anemia. Option C, vitamin D, does not touch folate metabolism. Here's a WGU D446 OA exam tip for you. Anyone on methotrexate should take daily folic acid to prevent side effects. Recall hook. Methotrexate blocks folate, so give folate back. 46. A nurse is caring for a client with a lower leg fracture in a new cast. The client reports severe pain, unrelieved by medication, numbness, and a feeling of pressure under the cast. Which specific complication should the nurse suspect first in this post-fracture client and report right away? A. Compartment syndrome from swelling pressure. B. Normal healing process just starting. C. Simple muscle soreness from position. D. Mild anxiety about the injury. Can you guess the answer? Correct answer, A. Compartment syndrome from swelling pressure. Explanation. Option A is correct, because compartment syndrome happens when swelling inside a closed space cuts off blood flow to muscles and nerves. Severe unrelieved pain, numbness, and pressure signal the need for urgent action to prevent permanent tissue damage. Option B is incorrect because normal healing causes mild soreness that medication relieves. Severe pain that does not respond to pain relievers is never part of routine healing. Dismissing these findings as normal would allow permanent nerve and muscle damage. Option C is incorrect because simple muscle soreness from position does not include numbness or pressure under a cast. Position-related discomfort eases with repositioning, while compartment syndrome pain is progressive and worsens despite medication changes. Option D is incorrect because anxiety does not cause numbness or severe pain under a cast. Attributing these physical findings to emotion would delay the critical surgical intervention needed to relieve the compartment pressure before tissue death sets in. Compartment syndrome is one of those emergencies where every minute counts, and the classic triad of findings in this question should set off alarms immediately. A compartment is a group of muscles, nerves, and blood vessels wrapped inside a tough layer of fascia which does not stretch. When the leg swells inside a tight cast or fascia after a fracture, pressure inside that compartment rises fast. Once pressure gets high enough, it squeezes shut the small blood vessels, feeding the muscles and nerves. No blood flow means no oxygen, and tissue starts to die within hours. The warning signs are the 6 Ps, but the early 3 are what matters most at the bedside: pain out of proportion to the injury, pain unrelieved by medication, and new numbness or tingling. The pressure sensation under the cast tells you the compartment is already packed tight. The nurse's job is fast: report to the provider, prepare for cast removal or fasciotomy, and do not elevate the leg. Option B does not involve unrelieved pain or numbness. Option C does not include pressure under a cast. Option D cannot explain numbness. Here's a WGU D446 OA exam tip for you. Severe pain, numbness and pressure after a cast equals compartment syndrome. Call right away. Recall hook, pain plus numb plus tight equals fasciotomy time. 47. A client returns to the unit after a transurethral resection of the prostate with continuous bladder irrigation running through a 3-way catheter. The nurse checks the drainage bag and notices bright red blood with clots. Which specific nursing action should the nurse take first for this post-operative finding? A. Stop the bladder irrigation right away. B. Document the finding without any action. C. Increase irrigation rate to clear clots. D. Clamp the catheter for 30 minutes. Can you guess the answer? Correct answer, C. Increase irrigation rate to clear clots. Explanation. Option C is correct because continuous bladder irrigation after transurethral resection of the prostate prevents clots from blocking the catheter and causing bladder distension. When bright red blood or clots appear, increasing the irrigation rate flushes the bladder and keeps the drainage system patent. Option A is incorrect because stopping irrigation allows clots to collect and block the catheter. A blocked catheter leads to bladder distension, pain, and possible bleeding from the surgical site. The irrigation must keep running to prevent this. Option B is incorrect because documentation alone misses the urgent need to act on a bleeding finding. Nursing care always pairs assessment with intervention, and bright red blood with clots needs an immediate response to protect the surgical site. Option D is incorrect because clamping the catheter stops drainage entirely, allowing clots to grow and bladder pressure to rise sharply. Clamping after transurethral resection of the prostate with active bleeding would cause painful distension and possibly damage the fresh surgical area. This question is counterintuitive, and that is exactly why students miss it. After a TURP, the surgical site inside the prostate bleeds for a while, which is expected. A three-way catheter with continuous bladder irrigation is set up specifically to handle that bleeding. Sterile irrigation fluid runs constantly into the bladder through one port and drains out through another, carrying blood and clots with it. The whole point is to keep the drainage tube clear so clots cannot clump together, plug the catheter, and cause the bladder to distend painfully behind the blockage. So when the nurse sees bright red blood and clots in the bag, the correct move is to speed the irrigation up, not stop it. Faster irrigation flushes the clots out before they can organise into a plug. Once the drainage clears, the rate can be titrated back down. Option A is the worst move. Clots will collect and block the catheter. Option B ignores an active intervention. Option D stops all drainage and lets clots and pressure build dangerously. Here's a WGU D446 OA exam tip for you. For clots after TURP, the fix is almost always increase the irrigation rate, not stop it. Recall hook. More clots equals more flush. Keep it flowing. 48. A client arrives in the emergency department with deep partial thickness burns covering 30% of the body surface from a house fire. The provider orders the Parkland formula for fluid resuscitation. Which specific type of IV fluid is used for this initial burn resuscitation protocol in this client? A. Half normal saline with dextrose. B. Total parenteral nutrition solution. C. Dextrose 5% in water. D. Lactated Ringer's solution for replacement. What do you think is the answer? Correct answer, D. Lactated Ringer's solution for replacement. Explanation: Option D is correct because lactated Ringer's is the standard fluid for Parkland formula burn resuscitation because its electrolyte makeup matches the extracellular fluid lost through damaged skin. It replaces sodium, maintains circulation, and prevents shock early on. Option A is incorrect because half normal saline with dextrose does not replace sodium aggressively enough for burn resuscitation. The hypertonic fluid and added sugar work for maintenance, not the massive extracellular fluid loss seen with large burns. Option B is incorrect because total parenteral nutrition provides calories and protein over days, not the rapid volume replacement needed in the first hours after a major burn. Nutrition support comes later, once the client is stabilised. Option C is incorrect because dextrose in water has no electrolytes and quickly shifts into cells. It cannot replace the isotonic fluid lost through burn injury and would worsen shock by failing to restore circulating blood volume. Burn resuscitation is about replacing massive fluid loss through damaged skin, and the fluid you choose matters a lot. When a large burn strips away skin and damages the tissues underneath, huge amounts of plasma-like fluid leak out into the interstitial space. Without fast replacement, the patient goes into hypervolemic shock within hours. The Parkland formula calculates how much fluid to give, typically 4 millilitres times kilograms of body weight times percent of body surface area burned, with half in the first 8 hours and the other half over the next 16. But the formula only tells you how much, not what. The fluid of choice is lactated Ringer's solution. It is isotonic, which matches the extracellular fluid the body is losing, and it contains sodium, potassium, calcium, chloride and lactate in physiologic proportions. Lactate gets metabolized into bicarbonate, which also helps buffer acidosis. Option A is hypertonic and too low in sodium. Option B is nutrition for days later. Option C has no electrolytes. Here's a WGU D446 OA exam tip for you. For Parkland burn resuscitation, the fluid is always lactated ringers. Recall hook. Burns plus LR equals textbook answer. 49. A client recently diagnosed with amyotrophic lateral sclerosis asks the nurse what kind of progression to expect over time from this motor neuron disease. Which specific clinical pattern of symptoms should the nurse describe as most characteristic of this particular neurodegenerative disease progression? A. Sudden seizures with full recovery after B. Progressive muscle weakness and paralysis. C. Memory loss with strong physical health. D. Brief tremors that resolve on their own. Can you guess the answer? Correct answer, B. Progressive muscle weakness and paralysis. Explanation. Option B is correct because ALS destroys motor neurons that control voluntary muscle movement, leading to steady muscle weakness, atrophy, and paralysis over time. Cognitive function typically stays intact while the body progressively loses movement, speech, swallowing, and breathing ability. Option A is incorrect because sudden seizures describe epilepsy, not ALS. Motor neuron disease does not produce seizure activity. The pattern in ALS is slow, steady, and irreversible muscle loss rather than episodic neurological events with recovery. Option C is incorrect because ALS spares cognition in most clients, but does not leave physical health intact. The opposite is true. The mind stays clear while the body declines. Calling physical health strong reverses the reality of the disease. Option D is incorrect because brief self-resolving tremors describe essential tremor or benign conditions, not ALS. Symptoms in motor neuron disease do not come and go or improve spontaneously. The progression is unrelenting muscle loss over months to years. ALS, amyotrophic lateral sclerosis, is one of the cruelest neurological diseases because of how it takes the body while leaving the mind intact. It attacks motor neurons, the nerve cells that carry movement, signals from the brain and spinal cord out to the muscles. As motor neurons die, the muscles they control stop receiving signals and slowly waste away. The progression is steady and one-directional. It often starts in one limb with weakness or clumsiness, then spreads to other limbs, then to muscles that control speech and swallowing, and eventually to the diaphragm, which causes respiratory failure. What makes ALS particularly hard is that cognitive function, personality, and senses stay intact. The patient watches themselves lose movement while their mind stays clear. There is no cure, and most patients live about 3 to 5 years from diagnosis. Option A describes epilepsy. Option C reverses the actual pattern. Option D describes essential tremor. Here's a WGU D446 OA exam tip for you. ALS is progressive muscle weakness and paralysis with cognition spared. Recall hook. ALS equals body goes, mind stays. 50. A client diagnosed with plaque psoriasis describes thick, red, scaly patches on the elbows and scalp that worsen during times of stress. The client asks the nurse about common triggers to avoid. Which specific factor should the nurse identify as a known trigger for psoriasis flares at home? A. Daily gentle moisturizer application. B. Drinking plenty of water throughout day. C. Stress, infections, and skin injury. D. Sleeping 8 hours every night. Can you guess the answer? Correct answer, C. Stress, infections, and skin injury. Explanation. Option C is correct because psoriasis flares follow stress. Infections like strep throat and skin injuries such as cuts or scrapes. These triggers activate the immune system and drive the rapid skin cell turnover that builds thick, scaly plaques. Option A is incorrect because daily gentle moisturizer actually helps prevent psoriasis flares by keeping skin supple and less likely to crack. Moisturizing is part of treatment, not a trigger. Recommending against it would worsen the skin condition. Option B is incorrect because adequate hydration supports skin health rather than causing flares. Drinking water does not drive psoriasis activity. Framing hydration as a trigger would mislead the client about basic self-care practices. Option D is incorrect because regular sleep helps manage stress, a known psoriasis trigger. 8 hours of sleep supports immune regulation and reduces flare frequency. Calling sleep a trigger would contradict what actually helps prevent outbreaks in this condition. Psoriasis is an autoimmune skin condition where the immune system mistakenly speeds up skin cell turnover. Normal skin cells take about a month to move from the base of the skin to the surface and shed. In psoriasis, that process happens in 3 to 7 days. The result is a pileup of immature skin cells on the surface, producing those thick, red, silvery scaled plaques on elbows, knees, scalp, and other typical spots. Flares are triggered by specific things that rev up the immune system. Stress is the biggest, which is why patients often notice plaques worsening during life upheavals. Infections, especially streptococcal throat infections, can trigger a specific type called gut 80 psoriasis. Skin injury, even small cuts or scratches, can cause new plaques at the site of injury, a phenomenon called the Koebner response. Other triggers include cold, dry weather, certain medications, smoking, and alcohol. Teaching centers on avoiding what can be avoided and managing what cannot. Option A, moisturizer, actually helps prevent flares by keeping skin from cracking. Option B, hydration, supports skin health rather than causing flares. Option D, 8 hours of sleep, helps manage stress and reduces flare frequency. Here's a WGU D446 OA exam tip for you. For psoriasis flare triggers, the answer is always stress, infections, and skin injury. Recall hook, SAS equals stress, infection, skin injury. You have reached the end of our first question set. For the free complete exam preparation, visit our website, link in the description, where you find thousands more practice questions and comprehensive study guides. Thanks for studying with us today. See you in the next video.